will now take a roll call of the membership for the minute of the meeting, and I would ask that members confirm they are present when I call their name. Councillor Lynn.
Present.
Pat Kilpatrick. Pat Kilpatrick. Okay, I'll mark them as absent or present. Councillor Short.
I'm here.
Thank you very much. Bailey Wright.
Present.
Anne Buchanan.
I'm here.
Thank you. Donald McPherson.
Yeah, present, Lily, thanks.
Diane McCulloch. I believe I've got apologies from Diane. Okay, Vicky Irons.
Yeah, present, Willie.
Thank you. Dave Berry.
Present, Willie.
Dr. David Wilson.
Yeah, present.
Thank you. Sarah Dickey.
Present.
Thank you. Raymond Marshall. Raymond Marshall. You'll mark them as absent or present. Jim McFarlane. Is Jim McFarlane present? Mark them as absent, present. Christina Cooper. Christina Cooper. You'll mark them as absent. Martin Sloan.
Present.
Okay, thank you. And finally, Dr. Emma Fletcher.
Present.
Okay, thank you very much. That concludes the roll call. When we've covered apologies, as well, item 2, any declarations of interest from any members to the content of the agenda as it stands. And there being no declarations, it then takes you on to item 3, which is in 2 parts. Firstly, you've got the minutes of previous meetings of the 23rd of February and the 25th of March. They're submitted for approval. Can they be agreed?
Does anyone have any issues with the minutes? Sorry, I got distracted there because it sounded like there was a jackhammer in the background. Yeah. I'll go through them page by page as I usually do. So, sorry, Willie, are we on there's 2 sets of minutes here. We're on the 23rd of February, so...
Yeah, thanks very much. Yeah.
Page 2. Yeah, Sarah's hand is up.
Apologies, Chair. In terms of the meeting of the 23rd of February, I'm on page 9, and the references in regard to the revision of the Dundee Health and Social Care Integration Scheme. I note the first bullet point references that the Tayside Getting It Right for Everyone group led on clinical care and professional governance. Please may I advise that it's not a governance group, that they would lead on the discussions that would facilitate and enable comments to be passed. Thank you.
Okay, if that could be amended, that'd be good. Let me just see. I think there might be another hand up here.
It's a short, Chair.
Sorry, say that again? No, that's it. There's
Sure.
no one else on that. Is it? Well, I was going through page by page. We skipped to page 9 there.
Yep, it was me.
Oh, it was Lynn. Councillor Short. Lynn, do you have a comment on the minutes?
One as well, okay, so just wait. Oh,
Sorry,
yeah,
I
I can just, yeah, mine is on the next one as well. Thank you.
Okay.
Then I can just wait because mine is on the next section as well.
I can't honestly hear what you're saying, to be Lynn. You might want to leave the meeting and come back in, see if you've got a better connection. We skipped to. Is there any other comments on the minutes of the meeting on the 23rd of February? No. So we move on to the budget meeting, which we held on the 25th of March. Are there any comments on the minutes of that meeting? Page 1, page 2, page 3, and that was it. A short minute because of the material that we discussed at that meeting. And I see no hands up, so can this be agreed? See, before we proceed, actually, as most of you will be aware, there are local government elections on May the 5th for Dundee City Council, which means that those members of the board who are councillors will cease to be members, it's my understanding. So I'd like to thank Bailey Wright, for who we may well see back here again, who knows, for the many years of service she's given to the people of Dundee, and particularly the service she's given as convener of social work for many years, as a previous member of NHS Tayside, and of course as a very valued member of the IJB. So thanks for the contributions you've made and your dedication, Helen. So as I said, we may see you back, but good luck in the election. And Councillor Short is a much more, who I'm not sure is on the call. Anyway, Councillor Short is a much more recent addition to the board, but has thrown herself into the role with great enthusiasm. So thanks for your contribution to Councillor Short, and who knows, you may be back, you may not. Same goes for me. So thanks everyone. I think we can move on, Willie.
You're not getting away with that, Ken.
Oh, sorry, Helen.
I mean, you have been there from the very beginning. I think we have to say thanks to you for the way that you've been steering the IJB, and thanks for saying so many nice words, and good luck to you as well, Ken. Thanks.
Thank you. Right, thank you for that. Can we move on, please?
Yeah, thanks very much, Chair. With the minutes of the previous meetings having been agreed, it takes you on to the action tracker, which is simply for noting.
Any issues? I think your hand's still up, Helen, but I believe that is just from the previous item. We're having a few technical problems today.
Yeah, I think so. It seems to be coming and going. I seem to be freezing quite a bit. On page 20, item 8, about the financial monitoring position, I noticed that it's been deferred due to other priorities. I'm just wondering what the other priorities, because it would have been nice to have had the answer to these things before finishing up in May.
I'll ask the Finance Officer, Dave Berry, to come in on that one.
Yeah, thanks for that, Ken. Thanks for the kind of query there, Bailey Wright. So, yeah, we've been continuing to improve the financial monitoring kind of report over the last couple of years. We've kind of added kind of other recommendations in as we've gone through. We're kind of bit short on staff. We've got kind of another accountant that's starting kind of shortly. So for us to be able to kind of fully can provide all the explanations that would be required in the financial monitoring report, we've been struggling for time to do that. So we've kind of we've made some improvements, but there's not the full kind of explanations against every sort of kind of significant variance that that's identified within the monitoring report. The reason I'm saying till August, because that's when we'll start in effect the 22-23 financial monitoring position. So that'll be the kind of the new financial year's kind of financial monitoring will move to a kind of a different format from what we've had with fuller explanations. Hopefully that's sufficient for you, Bailey Wright.
Thanks. Yeah. Thanks for that, Dave. I think it's quite understandable. If you are short of staff, you know, you shouldn't be under duress. Thanks for the explanation.
Anyone else on the action points? I see no hands. So, yeah, can move on, please.
Thanks very much, Chair. Item 4 is simply to note the appointment of Pat Kilpatrick as Vice Chair on the Integration Joint Board.
Yeah, thanks. I'm pleased to see Pat A join the board and B join as Vice Chair. My experience of Pat is that she's someone who speaks her mind, and I like that, because if there are issues or problems, we need to be made aware of them so we can fix them. So welcome to your new role, Pat, and good luck.
Thank you, Chair.
Okay, with that item having been noted, Chair, takes you on to item 5, which is the Clinical Care and Care Governance Report.
Matthew Kendall, I believe, is going to speak to this.
Yeah, good morning. Thanks, Chair. I'm Matthew Kendall, Allied Health Professions Lead in the partnership. I'll present the Clinical Care Professional Governance Report. This report would normally go to the Care Governance Committee, which it continues to do, but also the PAC. And because the PAC's not meeting for a little bit of time, we've been asked to bring it to the IJB, which is why it's here today. We've put 2 appendices onto the report, which carry the main body of the information, and they include the information from the last 2 governance reports that we've submitted. So there's a degree of I suppose repetition there, but the information is there for members to view, and I'd be happy to sort of take questions on them. I'll go through the report and just pull out some key areas. The data that we've got today is data running from October 21 through to the end of January 22 across both appendices. And there are 3 recommendations that we've got to note the contents of the report in the attached appendices, to instruct the Chief Officer to provide an annual clinical governance report for the year April 21 to March 22, which I will write and bring in June, if that's all right with the committee, and to note the level of assurance provided for this period is reasonable assurance. And just a note on the word reasonable in there, the Care Governance Committee have asked for slightly different measures to be used in terms of how we're measuring the assurance. So the 2 different appendices you've got different levels of assurance, but it means the same thing. It's just that the scale has been slightly changed, and we're working to a new standard there. So the key areas that I wanted to sort of draw through, and I'll go through sort of fairly quickly, but won't cover everything in the report because of the size of that. I'm going to start with the risks, and I'm working from Appendix 2 as the most recent report, but we'll reference back to Appendix 1 as I'm talking. So the risks, as you can see there, we've got 6 risks at Section A, clinical and care risk management. For quite some time, 4 of our top 5 risks have been in and around the Dundee Drug and Alcohol Recovery Service. That continues to be the case, but there's also a new risk that's been put onto the system. Our other top risk is sitting within the Mental Health Service. All of these risks really link back to, I suppose, the availability of staff that we've got and our ability to deliver the services that we would like to. Some of them link in and around resources and insufficient resources, but a lot of that is around the change in demand, the impact of COVID, and insufficient numbers of staff with specifically prescribing competences, which is really important through the DDAR service. Significant work has been ongoing over the pandemic period, and in this report, 2 of those risks, insufficient numbers of DDAR staff with prescribing competences and the impact of COVID, have actually reduced in this period, which has been really good to see because they've stayed fairly static over that period. One of the risks, as you'll see at the top there, the current risk score is in excess of the inherent risk score. That certainly has been as an impact of COVID and the way that that's impacted on a significant number of people and how they've needed to try and access the services that we've had. So reduction in our staff, but also a significant increase in the demand for services as well. But now that we're starting to get on top of that to a degree, I'm hoping to see that come down fairly soon. Recruitment and retention remains an issue across the whole partnership, which contributes to these risks. And there's a cyclical nature to this challenge in terms of sometimes we do actually report that we're getting on top of that and it's working well and we're attracting staff and retaining staff. And then 3 or 4 months later, that's reversed completely and we're struggling again. But it is a national problem. It's a problem across all professional groups, across all parts of the partnership and NHS Tayside. As part of the work to try and help mitigate that and mitigate some of the risks, we're certainly looking at the models of care that we use and that we provide. They're being reviewed and we're implementing different models of care. And there are examples of that through the paper, but we're certainly looking to try and preserve, for example, medical time to spend their time with the most complex of assessments with patients, and then asking nursing staff, advanced nurses, advanced AHPs and others to undertake roles to release the medics to do that. We're also working with third sector so that the pathway and exit strategies that we can implement for patients away from the professional staff can also be fully utilised. So significant work has been ongoing to address specifically the problems, but also to try and be innovative in the way that we are managing those. In terms of our governance and the way that we manage the governance systems, the risk system has had a number of actions that have been outstanding. So there's some administrative issues that we will need to make sure that we stay on top of. When we have conversations with managers, they are managing the risk, they are taking all of the actions forward, but they're sometimes not completing the information into the database that we hold. So it looks as though perhaps things aren't moving as well as they are. So there's a level of assurance that things are being done, but we need that level of assurance that the report and the paperwork is also kept up to date as well. The new risk, the bottom one that's in there, is around the benzodiazepine dependence pathway. And the current service don't have access to the resources in the community or a stabilisation inpatient facility to deliver prescribed diazepam detoxes, which is what's required for this patient group. So the team are currently working on identifying models and resources for residential rehabilitation for this client group. This is a national problem. There are not many DDoS type services or drug and alcohol services that have access to that. So we'll update the committee on that in future reports. Adverse event management, there's a lot of data in and around adverse event management. So I just wanted to bring people's attention to the top 5 categories for adverse events, which actually stays relatively static in terms of slips, trips and falls, violence and aggression, clinically challenging behaviour, medication adverse events and documentation administration. These are reviewed by local teams. They're also reviewed by primary governance groups and also by professional governance group, which meets on a weekly basis. So we're satisfied that there are no significant concerns that are presenting through these areas that require escalation. There is ongoing work, particularly focusing around slips, trips and falls, because that's consistently our highest one, and probably understandably so. I wouldn't necessarily expect that to change, but there's a lot of work ongoing to ensure that our inpatient falls, which this refers to, we've got all of the appropriate assessments and treatments, technology being used, that will review each of the slip, trip and fall incidents, that will review the harm to patients, to staff, and that will make sure that any mitigation needs to be in place that's in place. I'm happy to report that the level of assessment and management of those patients is high and has remained high throughout, and where any improvements are identified, they are implemented. We are doing work at this point in time for violence and aggression and clinically challenging behaviour to ensure that we get accurate reporting. A large number of the violence and aggression reports that are coming through probably relate more to clinically challenging behaviour rather than violence and aggression. And I think it's important that we can differentiate those, because if we're getting genuine violence and aggression incidents coming through, then we need to take a slightly different approach, I suppose, to support staff and to manage those incidents. So there has been an improvement in the way that they're being reported, but it's a work in process, and we'll continue to work with that over time. Medication adverse events, which is 4th on our list, is frequently 4th or 5th on the list, and is an area that I think we're interested in ensuring that we're very clear about what's causing those medication adverse events, and that we're making sure that every step is taken to reduce those as much as possible. We did ask our community nursing service to have a close look at their events, and this is in section B5 in appendices 2. And there's a subcategory of medication adverse events that are listed into there. The data they looked at was a 13-month period where there are some 28,000 visits to home where medication was administered. Often there would be multiple medications administered per visit, and there were 66 events over that period of time, which is about 0.2% of the visits where there was a medication adverse events. There are no patterns. There's nothing particularly of concern that's jumping out for us in terms of any particular team or any individual or any particular drug where there's an issue. So we do have a degree of assurance that this is down to individual human error. However, clearly there are concerns that there are medication adverse events sort of at all there. So the lead nurse is working with the community service to continue to review. Every time there is an event that comes through, there's a period of reflection for the individuals who have been involved in that. If needed, there's a broader team or service-wide adverse event review. But at this point in time, it's a piece of work that we'll continue to monitor and see sort of how we go. Pressure ulcers, intermittently, we get increased numbers. There's recently been an appointment to a tissue viability nurse in NHS Tayside. So our community nursing service and our lead nurse are working very closely with them, again, to review practice, which on our reviews has been very positive in terms of what's being done and making sure that all of the preventable actions are in place for pressure ulcers. But we want to sort of work closely with the tissue viability team to ensure that we're doing all that we can. Often, I have to say, because a lot of these ulcers develop in the community, the advice that's provided to patients I'll say is not followed, and that's not being critical of the patients. If people are in end of life care, or they want to choose to live sort of their life or manage that situation in a different way, then obviously they've got the freedom to do that. But we would ensure that we provide them with the information as to the best way to avoid the pressure ulcers and to manage those where possible. And then the other incident I just wanted to bring to attention is a never event, which is listed in Appendix 1. Never events are events really that you shouldn't see, as the name would suggest. And this was an unusual one in that it linked to the positioning of a nasogastric tube, which is a tube that goes through the nose into the stomach for feeding for those people that can't eat. There's a certain protocol that should be followed prior to feeding people like this, which involves looking at the pH level. If it's above a certain level, further tests need to be done to ensure that it's safe to continue with the feed. That protocol wasn't followed in this event, which potentially means that the feed can go directly into the lungs. So I'm happy to say that the patient that was involved with that is absolutely fine. They're continuing with rehab. There's no concern with that, but there is a local adverse event review with the ward in Ninewells where that occurred, and with the dietetic staff who identified that as an incident. But it's quite unusual, so I thought it was worth raising for members. Overdue adverse events continues to be a challenge for us in terms of unverified events, but also in terms of verified events. The unverified events, there's a number of these that actually have been submitted into the partnership, but shouldn't be there. They're vaccination. So we're working with the governance team to do some tidying around those, and a number of these have actually been managed since this event. The two red ones that are on section C1 in Appendix 2 linked to the benzodiazepine risk. So they've been linked into there, so they've now gone. The overdue verified events have been something that we've been working on for quite some time, and we've been balancing time between the newer events and the historical events, which still date back to 2018. The team are very keen to focus on the more contemporary events because the level of learning that we can get from that and support we can provide to the patients will be greater, but they will continue to work on the historical ones. It has been a period of absence for some of our key leads for this work, as well as the Omicron variant taking a significant number of staff away from clinical work. So the staff that would normally work on this have been rediverted. But there's a commitment to make sure that that continues. Complaints and feedback, there's quite a lot of information in complaints, so I'm not going to go through that in any real depth. We've got a very variable performance with regard to our complaints management. The most up-to-date information showed that only 20% of the complaints were responded to within 20 days. And I suppose to offer some assurance around there, a number of the complaints that we get are extremely complex, particularly in and around our mental health and drug and alcohol recovery services. And 20 days is a significant challenge for the teams. But to draw in the range of professionals that we need to and to uncover the complexity of the issues that are raised takes significantly longer than the 20 days. There is a commitment to try and work to that, and where we are able to, we do. And we are working with the complaints and feedback team through NHS Tayside just to look at processes to see where we can provide any improvements with regard to our performance around complaints. There's various information around complaints about the key themes, some learning from complaints. I'd be happy to sort of answer any questions if people want to ask anything specific about those in due course. The drug-related death section, this is really just an example of some of the wider thinking that the team have done in terms of improving efficiency within the work and also supporting those most in need for receiving care. The team have been working with third sector organisations to deliver the opioid substitution therapy for those people that perhaps are self-isolating or for those people that can't get access to the pharmacist to get the therapy. So we're aiming to reach out to people to make sure that they can continue to receive their therapy and their treatment. If that's not in place, there's a danger that they miss their medication, that they might lead to reassessment by medical staff, by senior nursing staff, which really impacts on the service's ability to deliver the care for the wider services. So I suppose to sum up, it's an ongoing challenging situation across the partnership. I think the teams and the services have continued to do an excellent job around the work that they're delivering, but also around engaging with governance. We have continued to have a comprehensive governance structure operating throughout this period, and it has sort of worked well. We've got a level of reasonable assurance, but obviously we can you can advise if you feel that that's acceptable or not through the discussion. And to move towards more comprehensive levels of assurance, I think really we're just looking at all teams having more comprehensive reporting across all parts of the governance process. And we've got a governance coordinator that we've recently employed that's working towards that, and also tightening up on the administrative functions, for example, completing the complaints actions and things like that. So I'll pause there and be happy to take any questions.
Thanks very much, Matthew, for that very comprehensive overview of the paper. I have a lot of hands up here, so I will bring them in the order that they put their hand up. So Bailey Wright, you're first.
Thank you, Chair. Matthew, there's two questions I would like to ask. One's on page 62. It's the rate of readmission to hospital within the 21 days per 1,000 discharges. We seem to be the highest in Scotland. And on page 58, the self-direct support spend on adults
Sorry,
were the second lowest.
sorry, have you moved on? I think you've moved on to item 7, Helen. We're on item
I didn't think so.
item 5. This is the page numbers you're given there. I think your questions are about the benchmarking framework.
Yes. Well, in which case then, I will leave it because I'll be away by then, but Margaret will ask the questions, I'm sure.
Okay.
Okay,
Yep.
Right.
Thank you. So
sorry about that.
Donald McPherson.
Thank you, Ken, and thanks very much, Matthew. I mean, this is a good report, and I find it really helpful to get an understanding of what's going on across the system. So thank you for that, and I'm pleased to see that there's some progress being made around those key risks within the DDARS service, because I must admit, when you pose the question at the end, is reasonable assurance versus limited assurance right? I think it would have been more difficult to come to that conclusion if we hadn't seen some movement in that area. Thank you for explaining what a never event is, because I have to admit, when I read that in the paper, I didn't have a clue. So thank you for that explanation. So just 3 questions from me, if I may. The first one is around timing of the reports, and I wasn't clear why today in April we were looking at a report that dates back to October and November of last year, because we have had meetings, both of the PAC and the IJB, in the intervening period, and of course currency with these reports is everything. So I wasn't sure whether there's just been a one-off glitch here, so perhaps you can explain that, please. My second question, you mentioned within the section around drug and alcohol about the MAT standards, and I was looking for some assurance as to when and in what form we'll receive reporting on compliance with those standards going forward, because they are challenging, and I think we will need to be on our toes to meet them. So that would be my second question. And my third one was just on your point around complaints, where you talk about they're not all being met within 20 days, and I can understand the reasons for that. I do draw a comparison with the the whistleblowing process, with which I'm more familiar with, where again 20 working days is the standard. At the moment, the average turnaround is around about 33 days, but there is a specific process to approve extensions beyond 20 working days, so that things don't just drift on. So I'm just wondering, does someone take ownership of the decision to extend beyond 20 working days, or does it just roll out? So these are my 3 points, please.
Great, thank you, Donald, and thanks for your positive comments at the start there as well. So this report wouldn't normally come to the IJB, so we added the 2 appendices which had the report that went back to October, which I appreciate now is a significantly long time ago. We report into the Care Governance Committee, and the Care Governance Committee ask for the dates for the reports to be reported in conjunction with the Clinical Care Governance Risk Management team. So we're kind of constrained to a degree by what we're requested to put into the Care Governance Committee and the data that we use there. Some of the narrative that we try and put into the report is slightly more contemporary, but the data is always constrained back to those times. So I will try and go in and look at the risks and give a much more contemporary position of those. The DATIX information will very much be the report that we've got for those timings. So there is a degree of, I suppose, overlap in that data, but I appreciate that it's a significant time for coming here. I think because we don't normally come to the IJB, that's why maybe you've got the slightly older data onto there. Sorry, I can't say any more than that really on that one. In terms of the MAT standards, well, I've just lost everybody. Is everyone still there?
Yeah.
I'm still here, but yeah, somebody's whiteboarding the looks of things.
Yeah, that's right. Someone's playing with the whiteboard. Okay. In terms of the MAT standards, I can't give you a direct response to that, but I can certainly ask the team. I don't know if any of my colleagues from the partnership are able to, but certainly that's a piece of work that Diane and the team will be working on. And I can certainly ask, oh, Vicky wants to come in. I beg your pardon, Vicky, do you want to come in on that one?
Yeah, thank you. And my screen's also gone a bit fuzzy, so I hope you can all hear. It was just to say that we are taking a report on MAT standards both to the Chief Officers Group and the ADP, so we can certainly arrange for there to be a further report coming back to the IJB in terms of implementation against that. But also following the Dundee Partnership meeting, which I think convenes in June, we'll have a much more the response to the recent Drugs Commission report as well. So in terms of timing, I think we can organise for a much more detailed report to come back to the IJB in due course. I'll make sure that that coincides though with the reports that are also going to Dundee Partnership.
Excellent, thank you, Vicky. And your last point about the complaints and the sort of the ownership of the complaints, yeah, the process very much is that if we are going to fall out with the timing of the complaints, that we would write to the complainant and advise them of that, and then there's a lead officer that would lead on the complaints, and they would take the responsibility for managing the complaint, pushing the complaint through. But the work that we're going to do with complaints and feedback team as well will also start to put other levels of sort of checks and balances into that process as well. So yeah, we do have a process there at this point.
Okay, thank you, Matthew. If I can just come back on the MAT standard point. Thanks, Vicky, for that confirmation. If that can be captured as an action, I think, for the minutes, please.
Yeah, totally agree. Yeah. Next up is the Vice Chair, Pat Kilpatrick.
Me.
Thank you. Thanks for your report. It was Matthew. It was really interesting. I sit on well, Annie's the chair, obviously I'm the vice chair of Care Governance, so we've seen a lot of the data, but it's great when you see it contextualised into the IJB. Just two questions really. One was when we went through the whole vaccination campaign, did we lose DDAR staff to the vaccination campaign? Because let's face it, it was probably a less onerous job and was probably relatively well paid, and I think it attracted lots of people away from different groups. And are they coming back? Are these people now? The vaccination campaign is, well, quite minimal now. Are they coming back? And the second one was, I note in the report it says that biochemistry drug screening is not delivering results for substances in a clinically useful timescale, and I think we would want to pick up on that because biochemistry screening is a automated service. It should be not really an issue. So those are my two questions, Matthew. Thank you.
Great, thank you. I know Vicky's hand went up with regard to the first one. Vicky, did you want to come in?
Yeah, and I'm not sure I can answer the second one, Pat. I may need to defer for that. The first one, though, in terms of staff, as you described, we lost to the vaccination service. I'm not sure that the turnover that we saw in DDoS was specifically as a result of staff going to the vaccination service, probably more for other reasons in terms of the nature of the role, and we've done a huge amount in terms of practice development to make sure that we are developing more sustainable and fulfilling roles for those coming into the service. I think you won't have had the benefit of the previous reports we've had from Diane on these issues, but certainly we also went through a phase of being able to successfully recruit a number of people to the service who then just had other choices in terms of their placements, and particularly with regards to new registrants. So those were the main reasons why we've had difficulties in terms of sustainability. I mean, there's no doubt that in other areas we did have a number of staff moving into the vaccination service. I don't have any intelligence, I don't know if Sarah does, but in terms of whether now the vaccination capacity needed is reducing, whether those staff are transferring back into substantive roles, but I can certainly ask for a report on that if that would be thought to be helpful.
Thanks.
Thanks, Vicky. I think that would be helpful just to understand it, and also I don't know what the grade these jobs are. Can they be regraded to be more attractive financially, or I don't know what we can do, because it's a critical thing for this partnership, and I don't know what we can do to make the jobs as attractive as we can do.
Yeah, I mean, we've looked at a whole range of issues, not necessarily just in terms of the grading, but also in terms of the opportunity for career progression and development, because all of these things are essential, particularly if you're working in quite a stressful and complex environment. It's really important for staff to see the benefits of joining the team and the ability to continue to develop. So we are working on all of those elements, and where possible, we're trying to do as much to make the jobs as attractive as possible. I don't think this is necessarily a short-term solution. I think it's something which we've got to continue to build over a period of time. But I do feel that as we move into kind of remobilisation plans, and as the service starts to be able to function from more distributed places across the city, where we get more engaged with primary care, for instance, that will make this a more fulfilling and attractive job. So it's an area where we've got a continuous work plan, and hoping that we can try and change the pattern of turnover that we've seen previously within the service.
You're right to highlight that issue, Pat, but I can assure you that we're very much focused on improving the service that we provide to people with a drug or alcohol issue. We've just, as has been mentioned, we've just had the Drugs Commission report, the final report back, which has been accepted by the Dundee Partnership, and I think we have a lot of work to do in implementing the proposals in there, which have all been accepted as far as I'm aware. Something we really need to stay on the ball about, because Dundee's record, historically and in the present day is not good. We've had far too many people die. So yeah, something that we are focused on, without a doubt. And next up is Annie Buchanan.
Sorry, Chair, nobody answered my question on the screening.
The what screening, sorry?
Biochemistry drug screening.
Oh yeah, of course, yeah.
Knowledge
that you had of that, actually, because I don't know much about that. Could anyone answer the question about biochemistry screening, which I think you said doesn't take long, so why?
Well, it's automated. I don't know if it takes, but I know it's an automated service, so it's a case of putting it all in an analyzer.
My understanding on this is that these are, and I could be wrong with this, so I'll ask colleagues to keep me right, but these are the post-mortem toxicology results that come back into the service, which is a national service. It used to be quite a responsive service, but more recently there have been challenges around that. So this has been escalated by a number of health boards about the concerns that exist. So work is ongoing nationally to try and address that and improve the service that's provided to us.
I think that's quite disappointing, because I chaired the first Public Health Committee in NHS Tayside, and it was an issue then. It was raised then, and that was in 2018. So here we are in 2022, and we still haven't got biochemistry drug screening right. Now that's if it's a national issue, it's a national issue. It's not necessarily within our gift, but I think we need to be putting pressure on Scottish Government or whoever is contracting it, whichever university or toxicology department are dealing with it. I don't think we can just say, well, 4 years later, we've still got an issue with the same thing, which is toxicology screening. You know, I know it's post-mortem, but, you know, families will want to know post-mortem. And previously people were waiting months and months and months, almost a year sometimes, to get results back. It's not, I don't think it's acceptable, Chairman.
Thanks for that. Annie Buchanan.
Good morning, Matthew, thank you. And as the new chair of NHS Tayside's Care Governance Committee, I do think that the reports that we're getting have definitely improved in the year I've been around, so thank you. I would like to commend the district nurses for doing that kind of deep dive into medication issues, and I think that would be a great thing to see replicated across the whole of Tayside. The one thing, Matthew, that I just was querying, I don't understand the difference between violence and aggression incidents and clinically challenging behaviour, and I'm wondering, from what you said, do you think people are double counting?
I'm not sure that there's double counting, but I think it is right that people do struggle to understand the difference. So a violence and aggression incident is a violent or aggressive incident. The difference for a clinically challenging behaviour incident is if somebody's condition leads them to behave in the way that they've behaved. So if somebody thumps you, or if I thumped you, that would be a violence and aggression incident. If somebody with dementia thumped you, that would be a clinically challenging behaviour incident. So that's kind of the differentiation that exists. Now in Dundee, we've done quite a bit of education work through our Clinical Care Professional Governance Forum. We did see an improvement from that, but we've still got some distance to go with that. But I think instinctively, people just see the violence regardless of the cause or anything that sits behind that and record that as violence and aggression. So we are able to distill that when we're reviewing those so that we actually do know how many incidents are genuinely violence and aggression and how many clinically challenging behaviour. We're just trying to make sure the reports reflect that and that people do the work, to report appropriately. Okay.
Sarah, can I bring you in? Sarah Dickey.
Thank you, Chair, and thank you very much, Matthew, for your comprehensive report. Just a couple of questions for clarification, please. Are the clinical and care professional members using the care opinion facility with regard to monitoring of concerns, feedback and complaints, or is it purely the system that's referred to in this report? The second question is, given the extensive work that the partnership's involved in regard to assurances around provision of care in the care home sector, I wondered if that might be something that would be of interest to members in any future reporting cycles. And then in relation to the medication errors, whilst it wouldn't affect the district nursing team, obviously we are part of the North of Scotland regional approach to adopting the hospital electronic medicines administration system, the HEPNA system. So certainly within the partnership areas, the inpatient areas will be very much part of that rollout programme across the North of Scotland in due course. And the benefit realisation studies with the HEPNA have very much indicated a reduction in medication errors as a result of implementation of the system. So thank you, but two questions.
Great, thank you, Sarah. In terms of care opinion, there's a mixed bag, I suppose, across the partnership. Some areas certainly do use care opinion, others don't, and people seek to get feedback in a variety of ways. But it's certainly something that we've been encouraging in terms of the use of care opinion as a central system that can be used across Tayside. In terms of the care homes, yeah, I think that the reporting for the care homes has gone through a particular route at this time, but I agree that reflecting some of the really good work that's going on there and the challenges that we've got would be useful in the care governance report, and I can certainly start to work with Colin, our lead nurse, and Krista around that. Interestingly, in terms of the medication errors, the district nursing service don't have either an electronic patient record or an electronic diary system, and I think some of that leads to some of maybe the confusion and the complexities that exist for the team in terms of delivering the services. So the systems that you've mentioned there, I think, will be very useful in terms of the management and the coordination for some of the services, and hopefully driving down some of the areas that we've seen.
Thank you, Matthew.
Last but not least, we have our Director of Public Health, Emma Fletcher.
Thank you. I was just going to add in response to Pat's point with regards to the vaccination service, given that that is our key role in delivery, and just to reflect that now that we are emerging out of that acute direct response to the pandemic, that workforce is much more stable. We had to surge in response to acceleration of the programme and access staffing through bank shifts, and really grateful to colleagues, organisation, to wrapping around it and supporting that as a whole system approach. The workforce is now much more stable, and we are doing the longer term planning in line with national recommendations. I would reflect that the whole vaccination workforce that we delivered in Tayside was one that was most strongly aligned to the ratio of band 5 to band 3s, therefore minimising the impact on our registered nursing provision as far as possible across the system. And also to reflect that, I think as Vicky has highlighted, my understanding is that the challenges within the DDARS workforce are across a range of professions. So nursing is a part, but also social work, management, but again, colleagues within the IJB, within the Health and Social Care Partnership will be able to advise. So just to reflect in terms of that wider context and where we are in terms of the vaccination delivery and impact on workforce. Thanks, Ken.
Thank you. I see there's no other hands on this, so we'll move to the recommendations. Can we accept the recommendations from 2.1 to 2.3 on this paper? No dissent, thank you. At this point, I would note that Bailey Wright has left the meeting, and I think you probably saw the message from us thanking everyone for their efforts over the years. And we are joined by Councillor Margaret Richardson, who is the named deputy for Bailey Wright. So welcome to the meeting, Margaret. Now, I want to rejig the agenda here because I know that David Shaw has joined us. So with the board's consent, with the committee's consent, I'd like to take item 17A, delivery of general medical services, Rye Hill Medical Practices next, which would enable Shona to contribute and then leave unless you wanted to stay for the rest of the meeting. What I would point out is that we are not taking a final decision here on the future of the Rye Hill Medical Practice. We are making a recommendation to NHS Tayside, who will make the final decision. So yes, if we could take this item now, that would be great. Who would like to speak to this, Shona or David or both probably? Yeah.
I think both, but if it's okay, I'll start off and then Shona can correct all my undoubted errors. So thanks very much for taking this item at this point. I'd just like to go through roughly how we're going to approach this. So my bit is really about how we got here, what's happened, what we've done, what happens next, and what it is we're asking of the committee. So how we got here, in general, there's been a problem with general practice really over the course of the last decade or so. That's not a Dundee problem, it's not a Tayside problem, that's not even a Scottish problem, it's a national problem. And reasons for that are quite complex, but it is what it is. We know that there's a problem in Dundee. We've done a GP sustainability survey. Out of the 24 practices, so that's all the practices in Dundee that completed it, 13 of them said that they had active vacancies, 6 of which had been unfilled 6 months after initial posting. In terms of what's happened in Dundee since 2006, we've had 6 practices merge, 3 practices go 2C and 2 practices close down. That's not an outlier. We are not different from the rest of Scotland, but as I said, that is the sort of background context. In terms of what's been happening at Rye Hill, well, they've had issues of one sort or another over the course of the last 5 years. We did design a program called Career Start to try and put in extra medical support into practices that needed a wee bit more stability, and we managed to find someone to go in and work for them, working 3 days a week for a couple of years. Unfortunately, There are only a limited number of these posts, so that hasn't been something that's been more active. In November 2020, they approached us to say that they had some sustainability issues. At that point, there was a combination of maternity leave and one of the GPs who was considering alternative options. We agreed to close the list. We've worked with them to try and reconfigure their boundary. We've put in practice manager support to try and strengthen their management team. Unfortunately, in December this year, so December 21, they approached primary care department to say that they did not feel that the practice was sustainable, and as such, they wanted to resign their contract. Now, at this point, I should probably tell you a little bit about contract stuff. Slightly complicated, so we'll sort of work our way through that. Most general practices are what are called GMS practices. They're governed by Chapter 17 of the GP contract, so they're sometimes described as either 17J or 17C practices, and you don't need to know the difference between those two. There are a small group of practices that are 2C practices. That is the chapter within the legislation that describes practices, which covers practices where the health board is the provider. So Rye Hill, it's a GMS practice. It's owned by its partners. They hold a contract with NHS Tayside. So ultimately, on contractual decisions, NHS Tayside decides what happens. Now, primary care is a hosted function, and that hosted function is taken on by Angus. So in terms of managing what happens in GP contracts, Angus has a role in discussing what happens at Rye Hill. So we've discussed this with NHS Tayside. That has been with Gail Smith and with Vicky as our chief officer supporting that. So that HSCP is also involved. Now, obviously, Rye Hill is a vital part of our health and social care infrastructure within Dundee, so it's only right and proper that there's an expectation that Dundee Health and Social Care Partnership discusses what they would like, how that fits in with our plans, because general practice is an important part of what our partnership is seeking to do. So you've got three main NHS players, the Tayside board, Angus, and Dundee. And in order to progress from the decision of the partners at Rye Hill to say, don't wish to continue anymore, we needed to make sure that all three were in alignment. And I think we've certainly worked hard to try and make sure that we are all on the same page. And I think that's been reasonably effective so far. Now, what our job to do, I suppose, is to try and make sure that what happens should the practice close is the best thing that can happen. And we've tried to define within this paper what that best thing is. So we want good access. We want access that's local to where patients are. We want something that supports general practice within the town. The last thing we want to do is to send a pile of patients to a practice that has no capacity for it and then watch the dominoes fall. We want something that's achievable. We can wish for unicorns, but if we can't actually catch one, then there's no point in saying that that is our preferred outcome. And we want something that is consistent with our overall direction of travel for Dundee. And as I said, those were our sort of core principles at the start of this. In broad brush, we put a whole pile of different options that we considered, but if you kind of narrow it down to three main kinds of things, you can either continue practice in GMS, either under the same provider or with a different provider. You can close the practice and do something with their patients. You can take it over as a 2C. We discussed all of these options with the existing partners. We discussed them with the local practices. We went through every cluster. We communicated with every GP practice within Dundee. We spoke with NHS Taysides. I was in communication with the medical director, the executive leadership team, and we have written out to patients. We haven't sought patients' views specifically. We're fairly clear on what those would be. And we have had limited time to embark on the sort of consultation that we would do if we had more options. Some of these options we just had to discount. I'm not sure what people's awareness of 2C practices is at the moment, but we have had very, very significant problems keeping our 2Cs going. We are only now starting to get into a more stable area, but in both Lochee and in Maryfield, we have really struggled to try and keep those well staffed. And we felt that if we tried to take this practice over, then we would be creating a very much larger health crisis. So I think I can see a route through now that we've managed to get some extra staffing into Maryfield to stabilise that practice. Lochee, under David Wilson, who's on this meeting, is again starting to look up a bit, but as I said, it's just not a sustainable option to take the practice over. We asked other practices if they could help, and no practice was wanting to take over the Ryhill surgery in its entirety. So that really meant that what we were aiming to do was to try and produce something that was going to try and protect as much local care for where people lived as possible. Now, Ryhill patients live all over Dundee. There is a preponderance in the West End, but they are all over the place. So it was important to see what local practices to the West End could do. And it was also important to see what other practices could do too. It was also important to try and make sure that we kept those clinicians who are working at Ryhill within the Dundee healthcare community. So these are the big things that we're seeking to achieve. So following our discussions, we've managed to identify 3 main practices that have capacity to take on the vast majority of the Ryhill patients. The list size at the start of this exercise was about 5,400. It's now come down to about 5,200. And we think we've probably got homes for just about everybody now. We were particularly interested in the nursing home that Ryhill put a significant amount of input into, and we managed to make sure that that particularly vulnerable group is going to be well looked after with a practice to go with. I haven't specifically name-checked the practices here, as I'm unclear whether that's something that that we should be doing in open business. But as I said, we do have homes. Now, no GMS practice was wanting to take on the last tranche. So for we think around about 1,500 patients, we think we have capacity for those patients in the Maryfield practice, as long as we have the GPs who are currently working in Ryhill move with those patients. So we think that we've just about achieved that. They're going on a practice visit. So I think our final outcome looks likely to be that it's those 3 big practices. There will be some other practices doing specific pieces of work round about that, and that will keep the domino issue of putting patients to places that have no capacity as being something that just won't happen. There's a huge amount of work to do when a practice comes to this position. So this set of negotiations so far has been the easy bit. The next thing to do is to try and actually operationally plan all of this so that it happens as smoothly as possible. As I said, we have written to patients, we have assured them that they have got good medical coverage right up to the end of the contract date. So they have full medical services up until the 30th of June. And we will be writing to them just as soon as we have heard from NHS Tayside and we have dotted our I's and crossed our T's to say, and this is where we would like you to go. There is a place for you here. This is what you do next. And behind the scenes, we'll be working on a smooth transfer of data and making sure that all of the clinical odds and ends that need to be tied up are done so. So I think that takes us on to, and what do we want this committee to do? I think it's important that NHS Tayside knows what Dundee Integrated Joint Board's view is on what should happen in its city. What we want to happen in the city is that the patients are well cared for, that we retain services within the West End so that there are local services for local people, local to where they live. We want to make sure that that is done in a considered and coherent way that does not get people trapped up in the mess. And I think the paper charts a route to that. So I would seek your opinion to see whether or not you endorse that view or whether you have an alternate view. I'll stop talking now.
Thank you for that. Shona, do you have anything you want to add to that?
Yes, thank you. I mean, David's covered the issues and how we've come to the proposed solution. I think it's absolutely key, and David said this already, to reiterate that this is not a position that we would choose to be in. We would not choose to close a practice, but obviously with the GPs terminating their contract, we've had to consider really carefully what the best option is, both for the patients who are registered at Rye Hill and also with the wider community across Dundee. We know that a lot of people, particularly older people and those with sort of complex healthcare needs, have a close relationship with their practice, and there'll be significant concerns from the patients. And we know that from the coverage there's been over the last few months, particularly for ongoing care. So we've had to consider that really carefully in terms of how we minimise the impact. Some of the way that the IT and information can be managed and working really closely with practices that patients may be moving to is really important for that. The other thing that we have looked at is what services can we continue to provide from the practice. So with the developing primary care team, we know that we have a range of practitioners who are providing care that traditionally would have been done by general practice. So the first contact physiotherapists are an example. They don't currently work from the practice. We don't currently have capacity to deliver care and treatment services. We might do wound care, phlebotomy, a range of other things that are not directly delivered by GPs or may have been in the past but are now delivered by others with specialist expertise. So we're looking at could we provide elements of that care locally to ensure that people who live in the local area can access that, and that would potentially help to support some of the other practices nearby who may not be getting all of those services as well. Obviously, for people that don't live within the area, there may be some of the care which would be provided more locally. So particularly when we're thinking around access, that's an important consideration. As David's highlighted, that the next step would be to take this to NHS Tayside for further discussion. Obviously, the timescale for this is relatively close now, so the communication and the coordination for this, and particularly how we link with individual patients, is important. Once we know what the outcome is, we'll NHS Tayside would be contacting patients further to let people know what the next steps would be for them to ensure that the care is managed as smoothly as we can do. Thank you.
Thanks both of you for that, and also for the work that you've done and looking at the various options around Rye Hill. I was a wee bit concerned reading the paper at 4.5.4 when it says a number of practices have noted that they may be able to register new patients to varying degrees. Well, you've addressed that concern, David, in that you've said that there are 3 main practices with capacity, which you don't want to mention, and that's fine. So that I'm partially reassured by that. But there are I'm wondering about the 1,500 patients remaining, because there still seems to be some uncertainty about whether or not the GPs will want to move to Maryfield. And if the GPs after the visit decide that that's for whatever reason not for them, do we have a plan for those 1,500 patients, or would they be able to move to Maryfield practice without the GPs or with one of them? Or
we have a set of contingency plans. There are practices that have offered to take on certain numbers of patients, so we think we can reduce our numbers down significantly through planned allocations, but it involves more practices than we would ideally wish. So we have our plan A and we have our plan B, I appreciate that the plan A element of moving them to Maryfield is desirable because it keeps that clinical team together and it keeps continuity for just under a third of Rye Hill with their previous clinicians, but it's not guaranteed. So we have a little bit of time to work that one through if it does not come off, but we are reasonably hopeful. I should add at this point that there is a financial consideration that simply is that there is a premium cost to running any 2C practice. This hasn't been any factor in our recommendation, but it is something that should be noted, that by taking on additional patients at Maryfield, we will be taking on additional costs. We think of approximately £80,000 a year, just because it costs more money when the health board runs practices, and I can talk at length as to why that might be, but let us just accept that that is how it is. My understanding is that a share of that will be met by Dundee, and the share will be met by Perth and Angus, and that may in itself be a bone of contention. But currently that is how the hosting and integration scheme would seem to be.
thank you, David. Now I have a few hands up, so I'll bring them in the order that they went up. Councillor Short is first. Lynn Short.
Thank you, Chair. I can't imagine anybody not wanting to go to Maryfield, doctor or patient, but maybe we're just a bit biased, Chair. By Maryfield, do you mean the cluster as opposed to an individual Maryfield surgery?
It's the individual Maryfield practice. So
that one now?
It certainly has adequate space, and our issue has been staffing it, but we think we're closer to being able to get adequate staffing. So that's now a realistic option for that smaller number of patients.
Okay, brilliant. One of my my reservations was basically the over 70s, and just change is never great any time, and change at the moment is perhaps even more of a burden. But Shona had mentioned that, so hopefully that's something very much being taken into consideration. The other bit was I've seen my doctor a number of times in the last 2 years, but for me it's been a revelation because I haven't had to take a bus to get from A to B to get to the doctor's to sit down for 5 minutes to then leave with a prescription in hand. There's no reference whatsoever in any of the paperwork with regards to, you know, the way that the society has moved. I'm presuming we would normally all be sitting in a room. We're not. Doctors can now do things in a very different way, and we've been pushed forwards because of COVID in different aspects of our life. Where is the kind of the digitalization and the movement towards that healthcare of the future? I once listened to a health secretary who said they wouldn't apologise for the problems of an aging population when it comes to health, because that means we're living longer. So, you know, it's just finding solutions as opposed to changing the way that we work. And the other thing was, when it comes to sweating the assets, my understanding is that Rye Hill is excellently placed. It's a large building, and there will be, obviously, because it belongs to the NHS, opportunities to effectively sweat that asset. I gave blood last week and it was in the Marriott Hall and it went like a fair. And it was because it was in the city centre. I haven't been for almost a year because it's been up at Nine Wells and I don't know where to go in Nine Wells and I'm scared to go up to Nine Wells at the moment. So are we looking at sweating it in a way that we might not have looked at sweating that asset pre-pandemic as well? Seeing as we've got an amazing building, which is in an incredible part of the city that's got buses going across its door every 10 minutes. Please.
A couple of things. Firstly, we haven't included stuff about IT because we wanted to keep the paper short. Absolutely any model is going to be reflective of the new ways in which patients and GP surgeries interact. So the current model within Rye Hill and the current model within Maryfield and indeed all the other practices that are involved in this is as you describe. It's a mixed model whereby there's phone, video, face-to-face. We have separately also been examining whether or not we can use an e-consult model to support email consultations, and we may have a provider elsewhere who may be able to assist some of our 2Cs with that. So that's currently working through Angus EMT. In terms of your points with regard to buildings, absolutely, Rye Hill, the building in which the surgery is located, firstly, I think only a minority is actually used by the surgery itself. Existing services are already present. We very much feel that we want to try and retain a more community-orientated approach to delivery, and premises are absolutely a premium within the partnership. We've really struggled to get services in the parts of the city that patients actually live, and we absolutely need to seize the opportunity here. So we are trying to make sure that any use of the Rye Hill building is seen through that lens. We want to prioritize things that are meaningful for people who live close to that area. So we have very much taken your points on board.
Chair, can I just actually come in with one last thing, please, if
Yeah.
you'll indulge me? Yeah,
Sorry,
I'm not.
I muted you, Councillor Shorts, because I thought that was where the background noise was coming from, but I think it must be David Shaw. I didn't want to mute him, so.
So basically, we're not going to pretend that we don't live in a political world, and it's a bit of a hot potato, as I'm sure that we'll all understand. Is there a way that perhaps the local members of the West End would be able to be briefed? Is there a briefing paper that can perhaps go from you, Vicky, to well, perhaps the West End, but also the wider, because it does have an influence on the whole city with regards to wars? Because I think, you know, there will be headlines come out of this, and it would be better if there was a kind of a sort of meat on the bones, as opposed to just the screaming headlines, if people actually understood the motivation, because we've heard it, so we understand, but we've got context.
Yeah, the papers are in the public domain, so any of the West End representatives would be able to access those. Do you mean like more flesh on the bones of the actual paper? Because we've heard information today, which I guess isn't in the paper. I guess that.
Yeah, a wee bit. Yeah.
So, may I come in, Chair?
Yes, Vicky.
Yeah, so in addition to obviously our consideration today, the details will be discussed through the executive management team of NHS Tayside. So I think depending on the timing of that, we should absolutely arrange further communication. I know that we have the backup of the communications team within NHS Tayside to to agree how best to do that. We've already had a considerable number of elected member questions and inquiries even since the very first announcement. So I think it would be prudent for us to keep people up to speed. And as you say, just to give a wee bit more information in terms of how we've reached this point. So I can certainly ask for us to consider that and arrange any necessary. I'll also be discussing it with Greg Colgan following today, just to make sure that it's not just IJB members, but elected members who are kept up to speed. As you say, this maybe impacts on a number of different wards, so it's important that everybody receives the same information. But as Ken said, all of the information that is contained within the paper today is in the public domain as it's in our open session.
Yeah, if I can just come in briefly,
Yeah.
a set of decisions made in the very near future, which will give much more clarity as to what's going ahead. So this is going up on Monday to Tayside's executive leadership team, and then we'll discover from them whether or not NHS Tayside board need to be involved. But either way, we should be getting a decision very quickly as to whether this paper is what's happening. The doctors are visiting Maryfield tomorrow, so we should be able to nail that element down, and that means within the next couple of weeks, I think we may well be in a position to say we've moved from something that's relatively high level strategic to something that's much more operational, and we can start to answer more specific patient questions. And that's probably the best time to actually do that elected member thing. I think it's an important representative function. You need to know what to say to your constituents. You need to know what questions to ask on their behalf. Quite happy to be involved in any of that stuff. I don't think I've got a joint role. So the reason, so I'm Associate Medical Director for Dundee, but I'm also Associate Medical Director for Primary Care. So it does make it slightly easier for this sort of thing, because wearing both hats means that I don't have to have another person in the room. So I think we can have a coherent group of people who can tell you a coherent story, which is going to be reflected in what actually happens in the relatively near future.
Thanks for that. Yeah, let's hope that we have a successful outcome, I guess, at Maryfield, because that would mean that we're not actually losing to Dundee GPs. They're just moving to another practice where they would be under much less pressure and be able to deliver a better service to patients. So, yeah, I hope that goes well. Donald McPherson's next.
Thanks very much, Ken, and thanks to David and Shona. I think, you know, it's always a complex and difficult subject, but I think both the paper and also the explanation that they've given today has been really helpful as we try and get our minds around this one. I mean, I suppose as I was reading the paper and listening to comments, I was sort of torn between whether this is a useful consolidation of services on the one hand, or, you know, the last straw for other practices in Dundee. And I think David's domino analogy was a very appropriate one. And I think on balance, I think it's more the former than the latter. But clearly there are some challenges in it. I think a couple of questions I had. The first one, we've spoken about the consequences for the GPs. We've spoken about the consequences for the patients. We haven't really touched on the consequences for those other people who are currently working within the RIHOPE practice. And I would hope that we're engaging with them, because, you know, we've got enough demands for skilled, you know, healthcare professionals, and so, you know, those that we have in the system, I'm sure we want to keep them engaged. So that was going to be my first question. And I suppose my second question is, we always end up having to be reactive in these situations, and I just wonder where we take the opportunity to take a couple of steps back and think, how do we actually in Dundee want to deliver GP services as part of an integrated health and social care partnership? And is this model of lots of different GP practices in lots of different locations in different arrangements, is that really where we want to go, or is there another direction? And should we be at some point taking those steps back and thinking about what's the right model for the future, given all the things Lynn's spoken about as well. The world is changing around us, the way we deliver services is changing around us. Do we need to change the model as well? So, one specific point, and one that's probably more far-reaching than we can deal with today, but maybe we need to start that conversation.
Just, Shona, do you want to go first?
Yeah, okay. So in relation to staff, absolutely, Donald, as you said, it's a skilled set of staff across all roles within the practice, and we're really keen to keep those roles. A number of the staff, due to the uncertainty, we know are considering other jobs in other practices. And actually, when you look on, for those of you that have got access to NHS Tayside's intranet, there's a significant number of general practice jobs advertised, but we are looking at that. We have agreed with NHS Tayside that although there's no obligation, because they're not NHS Tayside employees, they will go on to the skills register until the end of their current employment, if that's the decision to close. And we're optimistic that they will be found jobs that will utilise their skills well. So absolutely agree with that. Your second point in relation to being reactive and taking a step back, we would absolutely agree, and I'm sure David will come in and endorse that. I think COVID has, for all services, not just primary care, created a significant degree of change. Lynn's picked up on some of those already, and I was going to reply to Lynn, but David had responded to most of it. But the technology has changed the number of contacts that are phone now initially as a triage, some of it changing to video, some face-to-face. That's changed significantly with COVID. Obviously, it does cause concerns for patients because particularly older people that have got a close relationship and for some particular conditions feel it's much better face-to-face, but we absolutely need to embrace this change in technology. And I think for lots of people, we've been forced to change how we work regardless of our age. In fact, older people have, I think, embraced technology during COVID far more than other people have potentially. So it gives us a real opportunity. We are having ongoing discussions around particularly buildings. So there is something about small practices are probably less viable longer term than they used to be. So we're looking at not just buildings, but how that fits with a model for primary care and general practice delivery going forward. And that links to the developments with the primary care improvement plan. I know there's been some discussion about coming back to the IJB with sort of more information about primary care and general practice services and where we are. I think that's been picked up at a previous meeting, so we're having some dialogue as to the best way to do that and to involve the IJB with that. So absolutely, it's just a case of trying to find enough breath to get to the stage of being able to take that step back. And I think with the pandemic hopefully settling down and thinking about remobilisation, which is obviously one of the other papers today, I think it's a important time to be able to do that.
Yeah. Thank you for that. Kilpatrick, you're the last person with their hand up.
Thank you. Thanks, Chair, and thank you for the discussion and the explanation in the papers. And as you say, it's a national problem, and I think there is something in just what you said, Shona, about clustering practices together, creating larger networks of practice. I've worked in England quite a bit, and that's certainly a model down there where they maintained the viability of smaller practices because they brought them into a network. It's not without its issues and its challenges, but it has been successful in a lot of places. The point I was going to ask was, and I'm just asking this because I'm new to the IJB, I know places like Lanarkshire can attract people because they are, I think they have deprivation status, which I'm sure we probably have, I'm not sure, but I would have thought we would have done. Yeah. Anyway, they attract GP trainees because they can pay them a £25,000 golden handshake. And we all know that where people train, they will often stay because they develop relationships with people, their trainers are there, they create relationships and networks with secondary care physicians because they work in secondary care as part of their training. And I just wondered, have we got that, David? And is it something that would help us? Could we apply for it? Could we? It's just an open-ended question. Thank you, Chair.
Absolutely. Yes, we do have it, and we I think got that a year or two ago, and it has resulted in an increase in GP training places. I think the overall GP training numbers are starting to buck up, but it takes a few years for a pipeline to work through. It's 3 years to train a GP, so you've also got a variety of pressures that are pushing people out of the system. So in that sustainability paper, I think it's noted more than a dozen GPs who are planning on retiring over the course of the next couple of years within the city. So we have to work hard to keep our numbers up. In terms of both your and Donald's questions, it is absolutely best not to be reactive. We need to work out how can we be on the front foot, how can we be changing things so that there isn't another Rye Hill next year. I don't like coming to this committee and saying that a long-established GP practice that has been part of the lives of Dundonians for decades is coming to an end. That is not something I want to do again if I can avoid it. In terms of how it is you make general practice more sustainable, absolutely, you need to look at the model, and practices have, under some of the pressures that we've been talking about just now, they've been changing their boundaries so that they are more community orientated, so that they're tighter. We have experimented with models in Whitfield and Lochee of creating community practices that have a layer of other services wrapped around about them, so that it's a more integrated response. That seems to be working pretty well. If we can get a spot on the premises development, so that we have got new practices that designed so that people can get out of the quite shonky buildings that some of our colleagues still work from into something that actually has those synergies designed into it, then I think that goes towards building the community identity that makes a sustainable practice a sustainable practice. It isn't really so much about how many patients you've got, it's about whether or not you enjoy going to your work. So that those practices that have not succeeded have been often unhappy practices, or have been practices where people couldn't see a reason to join. Perhaps those who work there could see the reason, but they couldn't convince anyone else of their dream. So you need good premises, good leadership, a good model, and we are working on all of those elements to try and make sure that we have something that is more sustainable. Some of those things are in the hands of the partnership. Some of those things are in the hands of NHS Tayside. We need to tie the whole thing together, and also take the benefits that the Scottish Government programmes to support general practice have put into place. And beyond that, it's not just all about the GPs. So a significant amount of work needs to be done to make sure that we're getting the best out of our physios, out of our advanced nurses, and all of those other pharmacists and other professional groupings who are core to making sure that we can do that thing that patients need in order to make sure that their general medical services are dealt with appropriately.
Thanks for that. I have to say, I was quite despondent when I read this paper. At first, I'm not despondent now that I've heard all the work that has been done and the solutions that are being offered up to the closure of the GP practice at Rye Hill. I'm also heartened by the fact that we're at least talking about looking to the future and how not to be reactive, as Pat said, to have a solution in place that will ensure the long-term sustainability of GP practices in Dundee and perhaps in a different forum. So I'm certainly assured that lots of work has been done to look at the different options for Rye Hill, and although, as I said at the outset, this is not our decision, I am certainly happy to support the recommendations at 2.1 and 2.2, and 2.2, which supports the option to disperse patients across other practices and instructs the Chief Officer to make a recommendation to NHS Tayside to approve this option. Can we agree on this? I see no dissent, so thank you for that. Now, I'm really aware of the time. It's now 11:30. I'm thinking, and we've got quite a few items left. Well, more than half of the agenda we haven't touched yet, but it's clearly important that we devoted a lot of time to that item and indeed to all the items that we've had on the agenda. We will have to have a break at some point. I'm wondering if we should have it now, or I should perhaps take the next item and then have a break. Put your hand up if you want it now, quickly. or if you're prepared to wait until the next item. No hands are up. Okay, we'll go on to the next item, and we'll have a few minutes break after that, because we can't have everyone sitting for 2.5, 3 hours, or however long this is going to take. So I'm aware of your comfort break requirement. Yeah, Willie, next item, please.
Thanks very much, Chair. Yeah, it takes you back to item 6, the integration scheme.
Yeah, this is an agenda note. Yep, just wait till I get this up.
I'll pick up
Yeah,
this one if you don't mind. So yeah, so at the time, so that we have an agenda note on the on today's kind of meeting agenda. That was on the basis that there was a consultation process that was due to close on the 17th of April, i.e. kind of before we were actually going to meet, and members will be aware people have kind of contributed back. So thanks very much for all the comments that came back on the consultation process itself. So the original intention was, given the timescales, that we would, and I did, kind of put a consultation response back, taking into account the comments that were made by members back to the survey. I just found out yesterday that there'd been a decision made to extend it by another week, which then gives us the opportunity, should IJB members wish, to kind of make any further comment on the integration scheme itself, and just agree in terms of if there's a further response to the consultation that IJB members would want to see. I mean, I think it's probably fair to say, in terms of the responses that I've had to date, we did send out a kind of paper to cover what we saw as being the sort of the main changes, and not broadly things were just a kind of an update or a sort of kind of changes in wording and making it more kind of more reflective of the actual kind of practice of integration over the last kind of 5 or 6 years. But there were two areas in particular that, as professionals, we had some concerns about. One of them being around the changes to the financial risk sharing arrangements, which would see the addition of another element of that risk sharing arrangement, whereby if we were in an overspend position and had gone through the other steps in terms of trying to kind of pull back recovery of spend, change our strategic plan and use of reserves, that if the partner bodies had to put in a contribution to balance the budget, that would then be, may be kind of repayable back in future. So the concerns kind of were highlighted by ourselves around that one, because it was an addition. There was also the issue around corporate support, which has been a concern over since the inception of the IJB, and obviously kind of partner bodies have had a lot of pressures around the delivery of corporate support to their own services, never mind kind of supporting the IJB as well. So we were kind of looking for a more firm commitment around that, some form of SLA being developed around that side of things. So did get some comments back on those. In terms of the financial risk sharing in particular, there was a kind of small number of people, but probably still the majority, had kind of come back to say, yeah, we acknowledge the concerns around the financial risk sharing. However, the use of the word may kind of is quite important here, and it's not a fait accompli that's what happens. And in addition, I think, Donald, it was yourself that kind of put in some helpful comments around that we don't know, additional wording around that would only be agreed should the partner bodies and IJB acknowledge that there wouldn't be a material risk to the delivery of health and social care services as a result of that. So so that was kind of helpful. But I have had other comments to say no, they agree with the concerns in the paper that we'd raised, and wouldn't want that to be kind of shown as kind of put in the integration scheme as well. There's also another issue that again was just brought to my attention yesterday, we hadn't kind of picked up, and just really for noting, was in terms of the list of delegated services and the hosting arrangements, or the lead kind of authority arrangements. Inpatient mental health it does not appear on that list, and that's been
Yeah, does anyone have any comments over and above the comments that they've already made, as Dave mentioned? I certainly I was concerned about the risk sharing until I saw Pat's contribution. Then I found out that I completely agreed with her, particularly with the use of the word may. But I think it's important that we're financially responsible, and I don't think it's unfair that the words that may be required are in there. So I don't see any other hands, and this is an agenda note. And if no one else wants to add anything, we'll now have a 7-minute break. We come back at 11:43, please. Thank you.
Item 6 has been agreed to understand that you would like to now take item 15, which is the Audit Scotland report.
Yeah, please. That's page 163 on your agendas. And now, who's going to speak to this? I have a note. Yeah, Dave and Fiona's going to contribute as well. Yeah, obviously.
I'll just start just by way of a kind of an introduction, and I'll kind of pass over to Fiona for the rest of the report. Excuse me. So I think no members of IJB will have met Fiona before. She's been to IJB a couple of times. She's kind of oversees the audit team that will be the Audit Scotland team that continue to work with us in the IJB. And the report that we've got in front of you today is the proposed audit plan for the 2021-22 kind of financial year. So on completion of the draft accounts that we'll submit to the IJB for approval at the end of June, we'll pass them over to Fiona's team, who will then carry out the audit. But the audit has in effect been kind of ongoing over the last 12 months anyway, just through the external auditors being present at kind of IJB's, PACs, kind of ongoing discussions about various issues. So it's not just that everything starts from June, it's been an ongoing process. But I'll pass on to Fiona now. She can kind of take you through the detail.
Thanks, Dave, and thanks, Chair. Yeah, so as Dave says, this is describing our audit. It's our audit plan for this financial year, and presents to you our audit approach. And that audit approach is designed to comply with Audit Scotland's Code of Audit Practice and also international standards of auditing. And it describes our audit of the accounts and also what we call our wider dimension audit, which covers the wider aspects of the IJB's business, so financial management, sustainability, governance and transparency, and more wider value for money issues. And in planning our audit on the accounts, what we do is we look at our experience of the IJB and the environment in which it's working, and we identify any particular risks that there are for us in auditing the accounts. And these you will find on page 173 of your papers. So there's an exhibit there which points out the significant risks of material misstatement to the financial statements. So those are so material misstatement, that would be something so large that it would influence what the readers of the accounts were seeing in the accounts. And I'm really pleased to say there is only one risk there. And what that risk relates to a risk of fraud from management override of controls. And that's not because we think there is a particular risk in the IJB of that happening. It's a fundamental risk that international standards of auditing require all auditors to recognise, and that's in the extreme situation where management are in a unique position to be able to override controls because they understand them and they're responsible for authorising transactions. So all auditors recognise that as a risk and plan audit procedures to identify whether frauds have arisen from any management override. So as I say, not a concern, it's not because we found anything, but we carry out procedures to address that. So that's good news, you know, that's the only significant risk in terms of the accounts. And what that means is in our experience is that the accounts preparation process from Dave and the team is very robust. And we're expecting to be able to issue you with an unqualified audit opinion at the end of the year. But obviously a lot of work to do before we get to that. I'll then draw your attention to later on in the plan, so the audit dimensions and best value part of the plan, where we describe the wider scope risks. So if you turn to page 177 of the papers, what that describes is the wider risks that we're looking at, in particular in the IJB, either for the specific circumstances that you're experiencing in the IJB or because of the environment you're working in. And you won't be surprised to see COVID recovery and transformation as something that we'll be looking at and reporting in the IJB. And of course, all IJBs that I'm involved in the audits of. And so what we're looking for there is that the IJBs building in its response to COVID into the long-term plans, and that they align with the strategic and commissioning plan and all the financial plans going forward. So that's something we'll look at and we'll report back to you in our annual audit report at the end of the year. The second point we raised there is the integration scheme, and good timing, you know, straight on the back of that off the agenda there. So we were aware that the integration scheme was requiring update and that the process was ongoing for that. And so we were just flagging it there as something that, again, that we'll be monitoring and reporting on. The third risk is the board membership changes and development. And of course, you know, you'll have changes in the board due to routine membership changes. And there's, of course, the local government elections in May, which will bring about change for you. So on the back of that, it's really important that you've got plans in place to develop your new board members and to support them as they bed into their new role. And we know that's something that the board's been planning to do, but progress has been hindered by COVID and the situation the board's been in. So again, it's something that we're encouraging the board to get ahead of and be prepared, ready for this change in membership. So we will report on how effectively the board's responded to all of those risks. The final part of the plan then reflects on the timetable and the fees that we'll be charging for the audit. So the timetable, basically we're aiming for sign off by the end of October. And at the end of October, we'll present to you an annual audit report. And many of you will have seen those before, and they summarise our findings on all the audit work done. The exact date's still to be determined, but that's what we're aiming for. In terms of the audit fee, we detail what the fee is there, and I'm pleased to say that you've actually had a reduction in fee, and that reflects, I don't get to say that often, so that's good news, and that's because of the improvements that have been made to the accounts preparation process, the quality of the accounts over the term of our audit appointments. So credit to Dave and his team on that. So the rest of the plan just describes how we go about our work and the standards that we work to and our quality control arrangements. So I won't go into any more detail, but I'm happy to answer any questions that anybody has. Thanks very much.
Yeah, thanks very much for that, Fiona. Particularly pleased that we've had a reduction in fees. You mentioned new member development and support and how that's been hindered as a result of COVID, and I think that's really important. We really need to get a move on with that, because I think we're all used to meeting virtually as we are now, and member development and support can be conducted just as easily, probably easier, because you know we have quite a geographically diverse group here. Can probably be conducted easier.
Actually, this is the IJB, right? And boss says, can you go? And I went,
sorry?
Thanks. I didn't realise.
McAllister, could you switch off your? Yeah. Sorry about that. Where was I? Yeah, member development support. I think Annie's highlighted that as well. I don't think Annie feels that her member development support issues, and probably Donald too, I think he's kind of nodded there, feels the same. So we need to get a move on with that. And you have my commitment that we'll move on with that, although I may well be replaced by the time of the next meeting. But if I am replaced, I'll certainly ensure that that is highlighted as a priority for the next year in terms of our audit and well-being of, our decision-making process can only be enhanced by that. I don't see any other hands up, but thank you very much for that presentation. And we are asked to approve the proposed audit plan and note the contents of the report, which I'm certainly happy to do, and I believe everyone else is. So thanks very much, Fiona.
Thanks very much, Chair. Thank you, everyone.
Okay, thanks, Chair. If that item having been agreed, it takes back to item 8, the Strategic Commissioning Report. That's at page 67 of your agendas, and I believe that Catherine Sharp and Dave Berry will speak to the item.
Okay.
Sorry, I've just get the right paper up on screen.
Margaret, and just before you start, Margaret's hand's just gone up. I wondered, there was something you wanted to say.
I wondered, have I missed item 7?
I was waiting. I think were we out of order there now?
Government, yeah,
benchmarking framework.
Yeah, local government benchmarking framework.
Yeah, apologies for that, Chair. Yeah, I skipped over that one. Item 7 is local government benchmarking.
Yeah, no problem, Willie. I've changed the agenda around quite a lot, appropriately, but it's maybe confused us a wee bit. So yeah, it's actually item 7, which I believe Catherine's going to speak to.
Yes, thanks, Chair. I'll keep this brief in the interest of time. The paper that you've got in front of you serves two purposes. Firstly, it brings forward the performance information against the adult social care indicators in the local government benchmarking framework for 2020-21. This is an annual report that we bring normally to the Performance and Audit Committee, but it's coming today to the IJB because this is the only opportunity for IJB members to scrutinise the data before it's reported to the Council slightly later after the elections. So I'll not spend a huge amount of time on the performance because I think it's described in quite significant detail, both in the covering paper and in the appendix, other than just to note that obviously 2020-21 was a year in which performance across these indicators continued to be impacted by the context of the COVID pandemic. So some of the indicators around SDS, delayed discharge and readmissions, for example, need to be kind of understood within that context. The second part of the paper, which is really covered from section 4.8 onwards, relates to how we deal with reporting of local government benchmarking framework adult social care indicators in the future. And at 4.10 we set out some options for that, which really reflect the context set out in the paper in relation to concerns about the robustness of the suite of indicators and the resources that are required to produce the annual report, within the context that Dundee City Council have indicated they can intend to continue to report that to council committees as part of their kind of statutory obligations. But we don't believe that for the IJB it's a robust suite of indicators, that there's actually quite a significant overlap between this and indicators we already report to you. And that the resource that we use to report this could be more effectively used elsewhere. So we have set out some options for future reporting at 4.10 in the report, and I probably indicate that it would be our officers' preference and recommendation that option 2 is perhaps the best approach for future reporting, which would see us highlighting in our annual and quarterly reports which indicators are LGBF ones, and having them reported through that mechanism rather than creating a separate report each year. I'll leave it at that, Chair, and I know that people have questions they want to ask.
Yeah, I noticed Margaret's hand. Oh, Margaret's hand's up, but she's not appearing on the right. Oh yes, sorry, I just didn't scroll. Do you know what I wanted to? I mean, we have this every year, and I think I was the chair of the pack, so this came a year ago, and every year we hear that it's not really, doesn't really give an accurate picture of where we are. Just a couple of questions here. I noticed that something I thought was a bit odd on page 55, Appendix 1. It was one of the targets, hospital readmission rate within 28 days per 1,000 discharges. It seems like our target was to come last. That seems a bit odd.
Yeah, and that reflects in the position that we've reported to PAC previously in relation to our readmissions data and the challenges that we have in terms of the recording practice that's different in Tayside from other areas in Scotland. So our target took account of that it would be because of that difference, and we knew that there was no reasonable prospect of that position changing until that recording practice is resolved. On that point, we are making progress with that, and there will be a detailed analytical paper around readmissions to come to PAC in July, covering various aspects, including that recording issue that we've been working on with NHS Tayside colleagues.
It would have been unrealistic to aim any higher, that's fair enough. Councillor Richardson, Margaret Richardson, your hand's up.
Yeah, thanks, Ken. Helen wanted to ask about that one in particular about the rate of readmission, due to the fact that we've not been meeting targets. We're recorded as the poorest performing partnerships, and I hear that you're planning to bring a paper, but what work has been done around trying to reduce the rates of readmission in hospital?
I think we can set that out in quite a bit of detail in our next paper, because we intend to cover that and cover it as part of a pathway around unscheduled care and how readmissions interacts with some of our other indicators. But if Lindsay was able to be here today, what she would tell you is that actually the number of readmissions has come down. It's when it converts to a rate that there's differences in terms of how that's calculated and is impacted by the different elements that are taken into account in the conversion to the rate. So actually our number of readmissions is falling as an absolute number, and it's some of those issues that we'll be picking apart and setting out in some further detail in that paper in July, as well as updating on some of the improvement work that has gone on and the work we've been doing with NHS Tayside to try and resolve our recording differences that will allow us to scrutinise that data more transparently, including in benchmarking with other partnerships.
Yeah, the other area that Helen was interested to find out why the position was also poor was in terms of the self-directed support. It's on page 58, and she really wanted to know why that is, that it continues to be pretty poor.
Yeah, thanks for that. So the self-directed support indicator, actually up until the 2021 year, we had seen incremental improvements in that year on year, and unfortunately that wasn't continued into 2020-21, and as the paper indicates, there's obviously been an impact in terms of disruption to the provision of social care generally because of the pandemic, but also then the knock-on impacts that had on uptake and continued efforts around SDS. As you'll see in that appendix in those pages that you highlighted, there's quite a significant programme of work to address personalisation, including SDS, and the personalisation board are actually been looking in quite a lot of detail at how we might invest some of the additional funding that we get from Scottish Government, particularly to progress this agenda and to kind of build capacity and focus on some of that. I think we have a good idea of what some of the local barriers are that need to be resolved and progressed. And we're looking to build some additional capacity in the system to take that forward and obviously make up some of the lost ground from the COVID period, but to start to build on that and get back to that position of more incremental improvements over the years.
Okay, thanks for that.
Can I bring in Pat Kilpatrick? Oh, Pat's just, she's back. Yeah. I thought you disappeared, Pat, because your hand's up, but you're back and you're on mute. Pat, you're on mute.
Yeah, thank you for the report. Catherine, this isn't, I mean, I haven't as yet met the performance and audit with the audit committee, but this won't be the only performance report that the IJB produce. No, this is just a local government benchmarking framework. Was all the stuff around public health and mortality and primary care and mental health and all that, is that covered in other reports somewhere? Yeah.
Absolutely. So this is a very specific report, and traditionally
We're
we have
required to provide.
Yeah, and we bring it here because the council report it, and we think it's only right and proper that the IJB has the opportunity to scrutinise the data related to adult social care. That makes sense?
Yeah, thanks. That's all I wanted to know, Chair. Thank you.
Thank you. I don't see any other hands. So can we agree the recommendations from 2.1 to 2.3, please?
Agreed. Yeah.
Yep. And also, can we take note of the preferred option at 4.10? Well, if you could minute that, please, unless you probably already have, that would be good. Thank you. Next item is
Item 8, Chair, yes, Strategic Commissioning Report.
And this is going to be spoken to by Catherine again and Dave Berry, whoever wants to pitch in first.
Yeah, that's. I'm just going to make a start, and I'm going to let Catherine come in as well. And so, just in terms of kind of background on this one, you know, the IJB agreed back in February, or not that long ago, in February, to extend the period of the current plan up to the kind of end of March 2023, and since then, Catherine and the team have been kind of working through the kind of the various elements to kind of get us to a position to present to you today. In effect, an addendum to the report. So we had a discussion at the Strategic Planning Advisory Group around the approach, and it was deemed probably kind of most effective to, rather than rewrite the current plan, was to kind of just include an addendum to the current plan, really kind of focusing on the key actions that need to be undertaken over the course of 22-23 to deliver on the strategic priorities. So it was an update of the actions that were already in the existing plan, was deemed to be the most appropriate. As we'd kind of previously fed back from consultation discussions, the key priorities remained the same, so there was no need to change them. It was more about how we were actually going to deliver them was going to be the approach that we were taking. So there's been a lot of kind of work that has been kind of undertaken over a relatively short period of time by Catherine and her team to kind of get us to the position that we've got today. So I'll pass on to Catherine to kind of pick up on some bit more of the specifics around that.
Dave. I suppose the main thing that we wanted to highlight in terms of the addendum that you've got in front of you today is that there's been a really significant focus on incorporating the feedback that we received from the consultation and engagement exercises that we undertook with the workforce and the public. So Joyce Barclay and Ailsa McAllister led on that process, and we're really grateful to the members of the workforce and public who gave up their time to participate in that over a period in which we saw a surge in COVID infections. So it was really, you know, quite challenging, and we appreciate it with the time that people gave up to contribute. And we really hope that you can see that reflected throughout the document and the content and the way that it's formatted, that there has been, you know, a meaningful input from a range of people, and that is reflected in the final document. I think the other thing to note is that the kind of relates to the paper later in the agenda about COVID remobilisation, and the fact that a lot of the content and the actions identified for next year pick up the fact that our remobilisation efforts have become part of our business as usual approach. And again, a lot of the actions link back to mainstreaming some of those different approaches to service delivery, picking up on recovery in terms of reconnecting with people who've maybe been isolated over the pandemic period as well. The only other thing to highlight, just in terms of, we've had quite a focus on trying to make the document as short and as accessible as possible to the greatest majority of people, including, obviously, most importantly, the citizens of Dundee. And in that vein, Joyce has very kindly also produced a kind of further sort of very short summary version, a 2-pager that if it was approved today, we would intend to kind of publish and use as a keep in a public facing version of the addendum as well. final thing to highlight is at the end of the report, it just notes that we'll be moving on very swiftly to think about a replacement plan, because the extension, of course, is only for this financial year, and there is quite a lot of work to be undertaken in terms of a replacement plan. So the Strategic Planning Advisory Group that these chairs will be kind of turning their attention to that, and we intend to bring something back to the IJB in the summer, just updating on the approach and the timescale for that as well, taking into account some discussions we've had with community planning partners about the review of the city plan, but also with NH&S Tayside about their return to kind of annual operational plans and how we can start to align our planning a bit better across the whole system. That's as much as is probably as helpful to say at this stage.
Yeah, thanks for that. Very, very happy with the paper and the work that's been done. The only thing that I really noticed was on page 79 of our paper, strategic priorities, number 2. Happy with them all. It's mentioned the Wellbeing Centre, which is a major mental health initiative. It's at point 5, work with Alcohol and Drugs Partnership to progress the implementation of the MAT standards. I wonder if we could just widen that a wee bit more, given the importance of this issue, to make a mention of the working to implement the findings of the Drugs Commission, because it's not just about the MAT standards, important as they are. There's a lot more issues have been identified. So if we could just widen that one out a wee bit as a key action, I'd be happy with that. Is there anyone else has there any comments to make? Oh, I just heard a sound that I don't recognise there. What was that? Did everyone else hear that, like a bell? No, maybe not.
I do like a microwave.
I think that's given a text message.
I thought it was someone trying to want to speak, and it was a new way of alerting me. But no, so yeah, thanks very much. I think we can agree the recommendations then from 2.1 to 2.5. Thank you for that.
Okay, thanks, Chair. With that item being agreed, item 9 then before is the COVID-19 remobilisation report.
Yeah, I know that Vicky would like to make some remarks here, and then if you could come in afterwards, please, Catherine.
Yeah, thank you, Chair. So you have in front of you our remobilisation plan with a quite comprehensive set of updates in terms of the remobilisation plans which we've brought to the IJB on a number of occasions. And before handing over to Catherine, I really just wanted to take the opportunity to reflect on the place we find ourselves after over 2 years, obviously now having worked under pandemic conditions and what we describe as emergency measures. I think it's interesting, just in reviewing the papers for today, that we originally came to the IJB in the autumn of 2020, or certainly the summer to autumn of 2020, with our initial thoughts of remobilisation, and certainly that was on the basis of our previous knowledge of the course of a pandemic and the likelihood of us being able to remobilise and re-establish most of the services which we had put into emergency measures at the time. Obviously, we're quite some time after that period now, but I think from an IJB perspective and from a planning perspective, all of our services have been working in a continuous kind of evolution since that point to try and establish services in the form which is most accessible to people across Tayside, and also to try and provide more sustainable arrangements despite the significant impact that we've seen both in terms of demand of our services, but also the workforce. And I know that we referred to those previously, particularly when we were looking at one of our earlier reports, in terms of the level of risk which we're still carrying in that respect. So I didn't really want to say much more than that. I'm sure Catherine or myself or other officers would be happy to respond to any specific queries. But I think that the place we find ourselves now is that we have to move on, essentially, from continuously refreshing what we describe as remobilisation and recovery, and to look at the key themes which do have a legacy from the pandemic period and build those more into our strategic plans for the future as an IJB. And I think there's no doubt at all that our experiences, our collective experiences of the last 2 years has probably reshaped how we will provide some elements of care, in many ways, in very positive ways, in terms of making them more accessible, in terms of ensuring that we can provide the bulk of health and social care needs directly in people's own communities instead of relying on using inpatient facilities and the buildings infrastructure that we have across the system. So I think we've had some really important learnt lessons from the last 2 years, which will form part of the future of our strategy as an IJB. But we also need to be incredibly cognizant that the demand patterns in certain areas of service, again, those have featured today across mental health, across drug and alcohol related services, have changed beyond recognition for us all. So we need to now plan for those, but plan for those in a long-term way instead of it just being a short-term recovery exercise. So there are a series of recommendations within the report, but I'm happy just to pass over quickly to Catherine so that she can give you an overview of that. But before I do so, I'd really want to pass on my thanks to Catherine. We've heard a lot from Catherine today. There are still a number of agenda items which Catherine will be speaking to today. And I think the efforts that Catherine has extended in keeping all of our plans up to date, keeping all of the relevant kind of scrutiny reports and returns that we've been required to do has been extraordinary, as has it been across all of our services and our service managers and our heads of service. But really keeping us all in check and making sure that all of that information is presented in a coherent way is down to Catherine. So I wanted to pass on my thanks and acknowledge that.
Thank you, Vicky. Try not to have too red a face at this point. So there's not much else actually I wanted to say around this. So I think Vicky has really covered the main point of the paper and what's reflected in the appendix in terms of the extraordinary effort our colleagues have gone to over the last year to be able to move forward with the many and varied actions in the remobilisation plan, and bearing in mind that those were only the very specific and critical actions we reflected and don't in any way represent all the other things that they continue to do in the background as well. But really, by way of the kind of recommendations in the report in section 4.4, I think that what we're proposing now is that it is time, as Vicky said, to move on from having that separate remobilisation planning, that it's no longer a requirement placed on us by the Scottish Government or for that case in local authorities or NHS boards either. And across the whole of the public sector, we're now moving to start to kind of mainstream those remobilisation actions as part of our day-to-day strategic planning. And I think that's been reflected in the previous paper around our own strategic plan. And we've heard earlier from David and from Shona about how they're starting to reflect on some of the lessons learned into the longer term primary care strategy, for example. So it's our recommendation that this paper, I suppose, brings our separate remobilisation planning to a close, and that from now on we reflect that back as part of our business as normal approach into our normal strategic planning cycles, whether that's our overarching plan or those that are developed through our strategic planning care groups or at individual service level, and that would be the most appropriate use of resource moving forward.
Thank you for that. Seems a sensible approach to me. Councillor Richardson.
Thank you, Ken. I just wanted to get some assurances that going forward that some of the actions that are still ongoing or have been delayed with revised sort of timetables will be taken into other plans so that the board members can be updated as to the progress going forward.
Happy to come back on that, Chair.
Yep, go ahead.
Yeah, so although we're no longer formally required to report against some of the objectives within the remobilisation plan, they will now form part of both our strategic plan and our management action plan moving forward. As it stands, the Health and Social Care Partnership still meets once a week in terms of our Silver Command process for the COVID response. More lately, that has kind of morphed into a weekly meeting that looks at more generic risks which are present across the system, including some of the expectations and services we might be expected to provide in terms of the Ukraine response, for instance. So it would be my intention that we would keep some form of contingency style meeting, not necessarily every week, but for the foreseeable future, so that we can ensure that any of these residual actions that are in the mobilisation plan are taken forward, or that any new actions which are in connection with emerging risks are also managed effectively. So that will be something which we will ensure remains in place. And if there are any significant issues which arise from that, we will obviously ensure that that forms part of a composite strategic planning, sorry, that's hard for me to say, strategic planning report, which comes back to the IJB.
Yep, I think Margaret's happy with that. So thanks both of you for speaking to that paper. We're asked to, in the recommendations 2.1 to 2.5, to approve the recommendation that we no longer maintain a separate COVID-19 remobilisation plan, but as has been said, remaining remobilisation priorities are reflected in our strategic and commissioning plans and individual service plans. So yes, that's agreed. Thank you. I should point out that, see, if you don't wish to agree, can you just put your hand up, please? I think everyone knows that, but just to make that clear, that Annie's hand is up, so let's hear what you have to say before we agree that.
Vicky's already made reference, but I think for me, it's how do we make sure that some of this work finds its way onto a risk register? That's the only thing, because yes, it's about strategic planning and operational delivery, but it's also about making sure that the links are made. And I think, Vicky, you'd already kind of said that, but I just thought it would be worth making that point. Thank you.
Thank you.
Yeah, and we do have obviously another item in terms of strategic risk today, but I think that entire process has been under both intense scrutiny, but also refined over the period that we've just experienced. So I think I can give you an absolute assurance that these changing risks or changing factors that we see across the IJB will feature both within our forward look in terms of strategic plan, but our approach to risk management as well. And I think, if nothing else, in terms of the positives that we've gained from the last 2 years, I think it's made sure that all service areas are closer, are communicating more effectively, and if you like, raising the flag or giving us an early warning sign when there are things which are starting to be difficult. So we'll certainly, if you like, maintain that battle rhythm within the system, so that we've got an early indication from a management perspective of where there are key risks emerging, and that will obviously flow through to our kind of strategic reporting to the IJB. And certainly, again, most of the agenda items that we've already discussed today have featured some of those. We know that one of our biggest risks is around workforce, and David Shaw articulated those very clearly from a primary care perspective, but we've got early warning signs of where that's going to feature quite heavily in a range of other service areas as well. So these are the things which will kind of dominate our discussions and reports in the future.
Can I just come back, Chair? Vicky,
Yes.
I'm not suggesting giving anybody more work, but just listening to what you were saying about the positives, would it be worth trying to pull together something that shares those positives so that we can have that as a kind of step off? Because the way you've been talking, there's been so much good work done. It would be a shame not to recognise it, to log it, and to use it for the future. Is that a daft idea?
No, it's not at all. And particularly as I've just had a period of annual leave, for the first time in a long time, I've kind of had a chance to reflect on a very personal level. And I think without a shadow of a doubt, the last 2 years has definitely changed me as a person, but I think it's probably changed all of us, to be honest. And I therefore think it's really, really important for us as part of our collective recovery to reflect on the last 2 years and to be able to acknowledge some of the good that has emerged from that, as well as also not necessarily try and cover over the trauma that's been experienced across the system as well. So I'm sure there's a way we can do that can be more of a reflective piece, probably more of a development session, I would think, rather than a formal paper and a written agenda item. But I'm happy to speak to the team to see if we can pull something together. And I think for the IJB as a whole, that might be a valuable experience. So I would be more than happy to do that, Annie, and I think that's a good suggestion.
Okay, thanks for that. Well, I think we've already accepted the recommendation. So can we move on to item 10, please, Willie?
Yeah, item 10 then for his annual performance report, page 127 of your agendas, and I believe that Catherine's speaking to the item.
Right. I was going to say it's the last, but not quite the last. You'll hear from me today. So this paper obviously reflects some proposals that we wanted to make to the IJB in relation to a kind of revised approach to the production of our annual performance report. So this is the time of year when we start to think about the production of the report, and it's given us an opportunity to reflect on our previous approach, which is outlined in the paper, and some of the feedback that we've had on that from a range of stakeholders, most importantly from members of the public through some of our partner agencies, but also from some IJB members. And most of you will probably recall that for the last few years, we have had a desire to have a more fundamental look at how we deliver our annual performance report, but in the context of COVID, that's not been the right time to do so. But we feel that now we're moving into a stage where that is more possible. As the paper outlines, our historic approach to producing the annual report is very resource intensive. And we've taken that into account alongside quite a significant amount of feedback that we've had about, what that resource manages to produce. And whilst there's lots of very positive feedback about that from various partners, there's also some fundamental issues around accessibility, and also perhaps a focus on meeting our statutory requirements over maybe focusing more on the principal purpose of the annual report, which in our view should be about making sure that we have a open, transparent and accessible way of evidencing the impact of how we use public resources to deliver health and social care services to the citizens of Dundee as our primary audience. So we are proposing a different approach this year to the annual report. So section 6 covers this 6.1. So this year we're proposing to produce only a summary version of the annual report, but to do that in a more modern and digital format, which will allow it to be a bit more interactive and more accessible. So for example, being able to, record some of the same volume of information through video clips and those kinds of approaches, rather than relying on quite a lot of heavy written text to produce that, which we should make it more accessible to a greater number of people, whilst retaining some of the richness of the kinds of information that people have told us they found valuable in the past in terms of case studies and those kinds of ways that we've been able to evidence the impact on individuals and on communities. So we want to focus this year on producing a summary report, and partly that's also to enable us to release some resource to look at a more fundamentally different way of delivering the annual report over the course of the current financial year. So the report that will be for 2022-23. So instead of producing one rather large performance report at the end of the year, we want to meet our statutory requirements by taking a more incremental approach throughout the year, breaking the reporting down into editions that focus on each of our strategic priorities, probably with a 5th edition at the end of the year to mop up some of the governance and kind of strategic elements that we're required to report on under the regulations. We think that will give us a helpful way both for the members, Dundee citizens, but also for members of the IJB, a more kind of rolling approach to it. So you have more regular information in terms of the 4 strategic priorities. and will enable us to supplement that with other approaches. So having a more performance-focused element in the website, using our social media to pull some of that information through. So it'll be a different approach, and it'll be how we use that reporting throughout the year in total to meet our statutory requirements to publish annual performance information, but we hope in a much more public-facing and accessible way throughout. So those are our proposals. Obviously, we would be testing that approach next year if the board is happy for us to do that. And it might be subject to some adaptation. We'll be taking feedback throughout the process and wanting to revise that. And we know that things like the National Care Service proposals will have an impact on annual reporting moving forwards as well, so that we'll need to take those into account over the longer term. So there's going to be an incremental change to annual reporting over the coming years as well. So I'll stop there, and if people have what clarify approaches, that would be happy to do that.
Yeah, Donald McPherson.
Thanks, Ken. Yeah, can I just say I really welcome this approach, wholeheartedly. I think my observation is that huge amounts of time are spent producing long and complex reports that aren't particularly accessible to the public. And that's not a criticism of Dundee Health and Social Care Partnership. That's a criticism of the whole system across Scotland. So a couple of pleas, I think. The first one, what we often do is start by talking about our internal governance, and that's the lead into the report. And that, for anyone who isn't a governance geek like myself, that is enough of a turn off from going further into the document. So if we can look to start to focus on well the link, in particular the link between strategy, activities and outcomes, lots of use of KPIs to show progress over time, and graphics, and all of the options that we have if we're going towards a multimedia format. So I really look forward to this coming forward, and if you want to test progress along the way, I'm very happy to be involved in those discussions as well, if that would help. So look forward to it.
Donald, appreciate that offer, and to have a bit of a sounding board, because it will be experimental in its first stages, so to have some people to test that with. And what you describe is exactly what we want to move away from. There might be some governance things that we're kind of bound to report because of the regulations, but we hope to keep that kind of that fifth mop-up edition and keep the other ones much more public facing.
Great, thanks for your enthusiasm, Donald, and your offer of help. That's much appreciated. I see no other hands, so can we agree the recommendations from 2.1 to 2.4? Thank you.
Okay, thanks, Chair. Takes you on to item 11, the Mental Health and Wellbeing Report, page 131 of your reports. I believe Arlene Mitchell speaking to that.
Yep. Is Arlene here? Yes. Yeah, hi, Arlene.
Thank you. I will keep this brief. This report provides the IJB with an update about some of the key developments within mental health and wellbeing. Some of the developments have previously been reported, but are high priority in the city, particularly during this year. So an update is given. Some other areas are emerging developments, and I guess I would give the Veterans Service, the National Action Plan, as an example of that. There is some suggestion that there are a couple of areas from the report that require a more detailed report to be brought back to the IJB. I would give an example as the work that we're currently undertaking with the Independent Assurance and Oversight Group for the independent inquiry. The oversight group are with us until autumn time, so there will be an appropriate point to bring back a fuller report about the work that we've been doing with them. The one area that I hope to draw members' attention to is within 4.6. So there's a sentence within section 4.6 which refers to primary care mental health monies that have been received. there has been some update around the work that we've been doing on that since this report was produced. Shona Hyman and I are involved with a number of key colleagues in looking at how we can extend further our primary care mental health model. So that may be an area, given that we're required to produce an action plan with a financial framework to that. I would suggest that would be an area that the IJB will also want to see more detail around in due course. Sheila Allen, as you'll see, is on the call today as well. Sheila leads on our communities and inequalities work. So we did think between us, we would be able to answer any questions that members might have.
I see no hands. Actually, I do. I see Sarah Dickey's hand. Sarah, would you like to come in?
Thank you, Chair, and thank you, Arlene, for your report. As the Executive Armed Forces Champion for NHS Tayside, I was particularly pleased to see reference to the V1P work, but also the wider strategic national work on the mental health implementation plan. It would be helpful for me to connect with the local authority Armed Forces Champion in regard to my role, but also in respect to the wider mental health and thinking wider for citizens. I just wonder if we might make reference in future reports to the wider Armed Forces families that are within our communities and not just those that are veterans or serving reservists. Thank you, Arlene.
That's really helpful, Sarah. There's a report being prepared at the moment, and we will ensure that your comments are taken cognizance of within that.
Thank you.
No further hands. So thanks very much for that update. And we're asked to note the contents, obviously, and to ask you to ask for a further report about future plans for Veterans First Point Tayside. And also recommendations from Trust and Respect. So thanks for that.
Chair, for item having been agreed, item 12 then before is the carers investment plan. Page 137 for your agendas, and Catherine Sharp is speaking to the item.
So I'll just briefly outline the key bits in the report on Jenny's behalf. She's not able to be here today. So this is really the report seeking approval of a revised Carers Scotland Act investment plan for the current financial year based on the discussions at the Carers Partnership. So for this financial year, there's a budget of just over £2 million in relation to Carers Scotland Act investment and implementation, and the Carers Partnership have taken the opportunity as part of the 2022-23 budget setting process to revise the previous investment plan that they submitted to the IJB back, I think, a number of months ago. So there's two real key elements of this. The first is covered at 4.2 and in Appendix 1, that they've been able to update actual spends for the awards that were made from the monies in 2021-22 and are proposing that the underspends associated with that year, things like delays in recruitment, are carried forward where they can be by the organisations, releasing just over £100,000 for allocation into the current financial year. The second part of the paper relates to updating the allocations. So there were some provisional allocations agreed by the board previously in relation to the current financial year. So the board had already agreed the mainstreaming of £378,000 worth of investment back in August last year. But the Carers Partnership have now revised the rest of the allocations. That includes adding a proposal that £27,000 is used to support administrative support for the Carers Partnership. And there are other large commitments, including £250,000 for enhancing our approach to adult carer support plans, significant awards to the Carers Centre to look at streamlining approaches for replacement care to enable short breaks, to look at participatory budgeting in local areas, and also a large investment to increase the provision of non-chargeable respite. So some really important projects within that. Having taken the recommendations for the current year into account and the carry forward from the previous year, that leaves a remaining amount of just over 600,000 still to be allocated in the current financial year, and the Carers Partnership are currently working through proposals against that amount, which they're prioritising in relation to any gaps that they've identified in terms of the Carers Delivery Plan and the implementation of the Act. And Jenny's clearly committed in the paper there to coming back to the IJB for approval for those remaining amounts in due course. So Dave, unless there's anything else you want to add from a financial perspective, happy to take any questions and probably ask Dave to help with them.
No, I've got nothing to add. I think you've covered everything there, Catherine. Thanks.
There are no hands up. Yeah, thanks for this report. Investment in carers is key. We really need to provide better support to them. I think that it's carers that always are flagged up as the least satisfied group when we do surveys, and Martin's hand's just gone up to indicate that maybe he's not satisfied. Martin?
I'm always satisfied, Ken. In terms of the financial aspects, it's very important that the Carers Partnership is now really taking the ideas on of utilising the funds that's now available to improve the lives of carers across Dundee. There's still a lot of work to be done, and I don't think we're going to be anywhere in a good position in the near term. I think it's going to be something that's going to take a generation really to improve. So I'm glad to see that we're moving towards that sort of mindset within the partnership. In terms of the underspend, it's always from my perspective, it's always bad that we have to have that we've got an underspend. We really should be maximising our financial potential there. So that's something which, again, I'll be working with the Carers Partnership in making sure that minimise as much as possible. And just generally, I think the work that's going on with the Carers Partnership is an excellent one, and I think that it's something that I and carers who are aware of what's going on are deeply supportive.
Thanks for that, Martin. There are no other hands, so I think we can move on, having agreed the recommendations from 2.1 to 2.4. And we've got that 27,000, and we're approving that today as well, aren't we? For the admin support. Great stuff. Thank you.
Okay, thanks very much, Chair. Item 13 then, before we use the Strategic Risk Register. 145, I believe, like Claire, Lewis Robertson and Dave Berry will speak to that item.
Yep.
Okay, thanks, Ken. I'll pass on to Claire, and I'll come in if required.
So it's to note the progress made in our management, including we've agreed the Tayside IJB's risk management framework, and we've also held 2 IJB development sessions on risk management strategy and risk appetite. Also for the IJB to note the changes in the specific risks over the past year in the strategic risk register in the appendix, new risks and archived risks, and for the future work plan to further embed our strategic risk management across the partnership. So we've looked at the changes in our strategic risk register kind of reflect the changes in the risk maturity of the IJB as an organisation, and also kind of the significant changes in the external forces in the environment in which it operates. So I think when we first started with the strategic risk register, we had kind of quite theoretical ideas about what our strategic risk register was for the IJB, but now it really is got the kind of the real operational risks that have been escalated as well, including specific services such as drug and alcohol and mental health, and also the workforce specifically. So if you want to look at the appendix, Ellen take you through so staff resource, which we've spoken about throughout this meeting, is one of our highest scorers ones, and you can see that it has increased from where it was last year. And we've got also DDAS, drug and alcohol, a staff resource around performance, and primary care, including GP practice. So this kind of gives you an extract from the strategic risk register and tells you where things have improved or gotten worse over the past year.
Can you just tell me, sorry, what L and C means? It's probably obvious under current assessment. L's C.
Likelihood and
okay.
It's not impact. I can't remember off the top of my head. I'm sorry. This is the NHS
consequences, likelihood and consequences, maybe. No.
Yeah, this is taken from the NHS Tayside's kind of strategic risk format, the way to kind of give you an extract, and I'm afraid I've forgotten what C means.
Impact, although
but it's impact.
Although why does it C? But anyway, not to worry.
Oh, well, it will come back to me later. So that's the change over the past year. And
that's what I thought, yeah. Sorry, Emma's just said consequence, so I was right.
Yeah, and then for the future going forward, we're planning to look at to show the IJB members the Pentana risk management system, and also to really establish our risk appetite. So we've had that workshop, but we're going to take the feedback from that workshop and look to establish a risk appetite for specific risks.
Mm-hmm. Martin's hand is up, although it may be up from the last.
No, it's for this item.
That's okay. Go ahead, Martin.
I'm just looking at Appendix 1 on page 149, and the number of red elements within the appendix is quite surprising. Should we be concerned about the number of red items there or not?
Where it's red is to do with how it's scored. So if it's 5 by 5, that's the highest it could be, so that is going to be red. And where it's red in the second column, that's whether it's got worse over the past year.
Yeah.
So I think that reflects the talk about workforce. Workforce is an issue for the drug and alcohol service, etc., and primary care.
Right. So we shouldn't be concerned about the quantity or the level of the elements of red.
Can I just comment on that? I mean, Mark, I think quite right to kind of flag that one up, because I think the honest answer is that, as an IJB, we should be concerned about these areas, because that's why they're there. That's why we've kind of brought them up to your attention as an IJB. So if they are kind of quite a high scoring risk, that's our kind of current assessment. It's there for a reason, and I think it's kind of reflects back the transparency that's required for us to kind of give back to the board in terms of where things are. And as kind of Claire's mentioned, if you look at those areas that are red, probably just about every one of them we've either had a discussion today about in some form, or in a kind of previous meeting there. So it's about kind of reflecting these sort of kind of live issues that are there. Where we would start to get concerned is if we'll do another assessment this time next year and they're still all remaining at the same score. Now, some of them may well be, because there's not necessarily going to be something that we can do overnight to kind of to rectify that. So perhaps some of the issues flagged up previously around primary care this time next year we may still have issues around primary care. So yeah, I think it's a fair question to ask, Martin, but that is the reason why they're there. They are there for your purposes in IJB, the risks.
Cool, thank you.
Sarah, did you want to come in again?
Yeah, please.
Yeah.
Thank you,
Yeah.
Chair. And thanks very much, Claire, for your presentation paper on risk. In respect to one of the items in the appendice on page 155, reference category 1 responders, I'm just thoughtful that there's further work to be carried out to revise management and governance arrangements, and it was maybe just a suggestion for consideration to members that this would lend itself to a IJB development type session, so that each member has a much greater understanding of what it means to be a Category 1 responder and what our responsibilities and obligations therein are. Just a suggestion. Thank you.
Yep, welcome suggestion. Donald? Oh, sorry, Dave, did you want to come in as well?
No, sorry, I was just saying that's a helpful suggestion from Sarah. Thanks for that.
Donald?
Yep, thanks, Chair. One commendation and one question. I think the commendation goes to Claire and Dave for everything they've done over the last year. I mean, I think we have a much better view on the state of the strategic risks and what's being done about them. And that's only because of all the hard work that's been put in over the last year. So well done on that, and thank you. My question was just, one of the risks is around increased bureaucracy, and specifically around COVID response and increase in reporting requirements. And I see where that's unchanged. It's trending at the same level. And I think my question is, as we start to move out of the pandemic, are we confident that that level of bureaucracy is going to reduce? Because it's easy for Scottish Government or whoever to ask for lots of additional reports. The more difficult thing is to agree that there's no need to continue producing these reports. And so how do we make sure that that governance starts to fall away as we move back towards the new normal?
Yeah, I'll come in first. See, Vicky's got her hand up as well. Yeah, so I suppose that is one of the ones I'll be expecting to be completely falling away over the course of the next year, and we are starting to see some of these elements drop out. So obviously we just had a discussion about the COVID remobilisation plans, so there's no longer a need for us to report them back to Scottish Government. In a similar way, in terms of the finance side of things, we've had to do quarterly reporting in around our COVID expenditure for 22-23. That will drop away as well, but there are still some remnants of things that we still need to be reporting back on as well, which I'm hoping again they'll start to tail away over the course of the year. So yeah, again, that's one that we should see a gradual improvement on that one. Don't know if Vicky's wanting to add anything else to that.
I'm probably not quite as optimistic as Dave, I'm afraid. I think something has definitely changed, and I think there was absolutely a point throughout the pandemic period where the frequency of reporting was absolutely required, particularly as we were all getting to grips with the nature of what we were dealing with, but also all trying to share experience and information in terms of agreeing mobilisation and appropriate responses, but over time that has turned into just a propensity really for us to have to report on a very frequent basis, really quite a level of operational detail that we've never had to, prior to the pandemic. And I think many parts of the system have got used to that and have almost moved away from a kind of governing and a scrutiny role into almost a kind of operational oversight and management role. So I think it's going to be hard for us to pull back from that now, but we are certainly trying to do so, because it does create an extraordinary burden on the system, and I think Sarah mentioned earlier on the level of scrutiny, but also the level of support that we've put into care homes throughout this process, and whether that should form part of our reporting arrangements, particularly our clinical and care and professional governance arrangements moving forward. And I think that's a really helpful suggestion. But that's just one example of one area which had really not appeared on anybody's radar prior to the pandemic, but all of a sudden just became an entire industry with regards to reporting lots and lots of finer details. So I think this will be a journey for all of us to try and pull back and to try and establish a system where we're reporting on what matters and we're reporting on the issues where there's benefit from national kind of thinking, national scrutiny and national governance, as opposed to just reporting for reporting's sake. And I know that certainly from my own perspective, where we were dealing with some really tricky issues, there was a tendency just to increase the prevalence and the frequency of reporting as if that in itself might resolve the issue. And quite clearly, it would be better if we utilised our time to be able to think and work through the problems rather than just record and report. So we'll have to see what emerges, I think. But there may even be an opportunity for a kind of national discussion on what essentially performance management looks like moving forward and what scrutiny and assurance looks like moving forward, because I think we all need to draw breath to a certain extent to get that into the right place. And I'm just super conscious that, particularly as an IJB, we're going through a journey over the next couple of years that leads up to the establishment of a national care service. So I'm particularly keen to ensure that scrutiny, assurance, performance is all levied at the right level, so that we don't necessarily use unnecessary time in just kind of feeding that machine, as it were.
Emma's up next. Emma
Thank
Flick.
you. I think this is the level of discussion reflects how valuable this item is, and to see everything laid out is really, really useful. To reflect the previous discussions insofar as, yes, absolutely, don't want bureaucracy for bureaucracy's sake and where it delivers best impact. And apologies if I've missed this either through the development sessions or in the paper, but I'm just thinking in terms of the risks that are defined, and particularly the ones that are red and high, what happens in terms of those risk updates? What's the next steps? And I'm thinking in terms of the governance structures within NHST side, each of the strategic corporate risks are presented and reported to a standing committee of the board for that regular assurance and to understand the progress being made. So I know that we've covered off discussions about a good number of these, but apologies, I'm still getting used to the IJB structures and wondering what happens next in terms of the risk reporting. Thank you.
Yeah, thanks for that, Emma. I'll come back on that one. So there's regular risk reporting to the Performance and Audit Committee. So there's the opportunity there to kind of have more scrutiny. So we're bringing this as in effect the annual kind of overview of that process. But you would have that opportunity through PAC for that discussion. I mean, again, it gives the opportunity, back to what I was saying in terms of kind of Martin's response around, we should start to see things progress, and IJB members or PAC members would be kind of asking, well, why is that not moving? Gives you the opportunity to kind of find out a bit more around the mitigating actions, and that's something certainly we've kind of discussed at the IJB development sessions on risk that Claire kind of again mentioned there around the kind of access to the Pintana risk management kind of side things, so members can actually be able to kind of look at things in real time to say where is that risk sitting. There's an update due, or no, there's just been an update due on that one. What's the mitigating actions that have been put forward to reduce that? So that will continue to develop over the course of this year, but there are other opportunities other than just this kind of once a year opportunity.
Okay, Margaret, please. Margaret Richardson.
Oh, thanks, Ken. My question is around, again, the highest scoring risks and in terms of the staff resourcing and things like that. It would seem almost that this is, needs to be addressed more at a national level than at a local level. However, I think it might have been a bit useful to see some of the mitigations that are possibly in place at the moment or are coming online in the future. I mean, there's been some stuff in the papers and in the news recently about the vaccinators now coming to join, and quite a few of them now working for the NHS in various roles, and how that's going to ease pressure. Also about the new nursing posts that they've managed to fill from abroad. But the very fact that this is at the very top level that it can go, I think it deserves more explanation as to, okay, it's maybe everybody understands it is a national issue, and not just in Scotland, across the UK, but I think there needs to be, give the board members a bit more detail about what you think would be mitigating circumstances in such a challenging position.
Yeah, thanks for that. I think that's quite helpful kind of reflections there. So no, when we kind of look at either the regular reporting or the similar report for next year, we'll take that into consideration. So you're right, you need to know what's actually happening, what are we doing about it as part of that. So we'll take that on board. Thank you.
Yeah, thanks for that observation. I think we can now move to the recommendations. We agree the recommendations 2.1, 2.2 and 2.3, which are actually all for noting anyway, so not really a need to agree, but we have anyway. So next item, please.
Yeah, thanks very much, Chair. Item 14, employees reshaping non-acute care. That's page 155 of your agendas.
Yep. And speaking to this, we have, oh yeah, Sarah Simpson. Welcome, Sarah. You're the project lead.
Hi, thank you.
Hi.
Thank you for inviting me along. Okay, just want me to start. So yes, thanks for inviting me along today. My name's Sarah Simpson. I'm the project manager within the new works team at NHS Tayside, and I've been assigned to this project. There's myself and Mark Moody appointed to this one. So Mark's our construction and development manager as well. Current project status, we've now got a project team and a project board established for this project, and we meet on a regular basis. We're also providing regular progress update reports to this group and also to NHS Tayside's asset management group. All key project documentation is now in place and is approved by our project board, and it's updated and reviewed on a regular basis. So just to give you a little bit of background, so this project's at initial agreement stage. It's part of the Scottish Government Capital Investment Manual process that we follow. So we've got initial agreement stage, then we would move, once we've got approval, we move to outline business case stage, and then full business case stage, and then on to construction. So at initial agreement, we're basically looking at, it's the clinical brief for the project. It's the need for change. It's why we're doing it. It focuses on the clinical solutions for the project. The why, really. It's in 5 chapters. It's probably the easiest way to describe it. So we've got the strategic case, which is the clinical brief, the financial elements of it, which are in 2 parts, commercial case and the management case. The strategic case for this project is now had its first draft complete and is with our project team to review and comment before coming back, and then we'll send it to the project board to have a look. The management case, which focuses on the governance arrangements, the commissioning, the project management status of the project, and the roles and responsibilities for all our team members, is also now complete, and that will be circulated shortly to everybody as well. We're in really 3 parts to get the business case to Scottish Government for approval. So the initial agreement, which is our main document, is one element of it. The second element is that we go through a design assessment process, which is facilitated by Health Facilities Scotland. We started this process at the beginning of the year. The first workshop we had was, it's called the ADET, so it's Achieving Excellence in Design workshop, which provides a benchmark really for what you've currently got, where your services are currently hosted. So that was mainly looking at Royal Victoria Hospital and Kingsway Care Centre. We pulled together quite a large stakeholder group for teams, as large as we could. Obviously with COVID, what we used to do would be we would fill a room with everybody, have an open invitation, everybody would come along. But with COVID, we can't do things the way we used to, so we've had to kind of limit it. But on the stakeholder group, there's good representation from clinicians, HPs, admin team, and as well as patient and carer representation. And they're a really, really good group who have a really high level of participation and have been keenly involved in the process. So we've done our benchmarking. Our second workshop we held was the design statement, where we look at what you would like, what's your ideal, what would be, if we could give you anything, what would your ideal facility look like? That's completed too, and then that gives us a design statement document for as part of the business case as well. So our final workshop in that series, and that'll complete that element of work, is we're having a workshop on Friday afternoon where the group come back together and they choose images to populate the design statement. And once that's complete, then we can start to circulate that round to other people for their comments and input to that as well. So that would take that part of the process to a close. The third and final process is a new one. It's National Services Scotland Key Stage Assurance Review process. It's a process that's relatively new to everybody. It was implemented on the back of the issues that were occurred in Glasgow with the hospital there, and it provides like a governance check and a review on your project before it can go to Scottish Government. You have to have their approval before you can submit your business case. It's quite a lengthy process, it's quite onerous, it goes into great detail. At our stage, at initial agreement stage, because we won't have designs or drawings, they will just be looking at our governance arrangements, how decisions are made, who's on our team, what our qualifications and responsibilities are, just that kind of thing. So I have started to prepare us to commence that process as soon as we can. So our next large part of work would be our solutions appraisal exercise, which is due to take place on Wednesday, the 27th of April. We'll come together, we've got a long list of clinical solutions. The group will look at the advantages and disadvantages of each solution and score each one, which will give us our short list of solutions that we then take forward onto the next stage of the process. And this will then allow us to start to cost things up to complete the initial agreement. I think that's about it for what we're at the moment. Once we've got our initial agreement, we can start to commence on our governance process, and we'll bring that back to this group for approval.
Thank you very much, Sarah. And you know what, I haven't made a big deal about how kind I am at bringing items forward in the agenda to let people away. You've sat here for 3 hours to speak to this paper, and I'm really sorry. I should have looked more carefully and realised that you were here for that one item and you could have got away a lot earlier. But having made that apology yet, this is really good stuff. I'm really pleased to see that inpatient accommodation will improve as a result of this, because no one wants to be in hospital in the first place. And if your surroundings are about, I don't know what age RVH is, but maybe it's Victorian, some of the surroundings just like the name. So yeah, great, good work, and look forward to see what comes out of this. Dave?
Yeah, thanks, guys. Just to add to what Sarah was saying, I think it's probably fair to say that we've made more progress in this project over the last few months since Sarah's been appointed than we have done in kind of quite a number of years. This project actually predates integration in terms of a concept, so there's been a couple of kind of false dawns in getting this one moving. But I think from what you've heard from Sarah today in terms of where we're at with the kind of various stages and the work that's been done, we are in a very good place now to kind of be able to actually deliver on this project. So just want to kind of add that background for IJB members.
Yeah, great stuff. And if I hadn't taken a 3-hour chunk out of your day, Sarah, you might even have more done by now. Sarah Dickey's next.
Thank you, Chair, and thank you, Sarah. This is another Sarah. Thank you very much. Really welcome the report, and as Dave has outlined, this has been outstanding for quite some time, so it's really quite exciting now to hear that we're developing at the stage of initial agreement. My question for clarification, please, Sarah, is as part of the assurance steps that you'll be taking as part of the workshops, obviously workforce will be critical to the clinical models that will be designed as part of this brief. So I just needed assurance that specific attention will be paid to the workforce requirements aligned to those new clinical models.
Yes, we have representation because it's a number of different services. We've got representation from each service. It's been opened up quite widely. We've also got staff side that sit with us as well, and they've been invited along to each part of it. And where people haven't been able to attend due to a variety of reasons, we have included them in the circulation of everything from each workshop. So they've had a chance to input into the documents.
Thank you, Sarah.
Yeah, thanks very much. Pat Kilpatrick, before I started looking at Pat's hand's up yet.
Yeah, thanks, Chair, and thank you, Sarah, for your report, and it's all good stuff. I just wondered if at this early stage you had considered building a health and social care hub onto this facility. I'm just thinking about the discussion we had earlier about the future of general practice, given we've got old age psychiatry and we've got neurological conditions, we've got stroke, we'll probably look after Parkinson's patients there, we've got palliative care patients. I'm just thinking if that might be a way of integrating, because if you look at GP careers now, people want to be able to do other things rather than 5 days a week. In fact, very few GPs work 5 days a week in general practice. I think it's too stressful and it's too repetitive. So if you want to keep GPs in the profession, it's 2 days a week in something else and 3 days a week in practice, and that's portfolio working. And I just wondered if we were talking about primary care premises earlier on, and I just wondered if we could, and we've done this in other places in Scotland, is build a care home facility in some places and put a health and social care hub on. I just wondered if it might be something. It's maybe too late now, but I would always encourage, to have co-location, because also you can get GPs to provide some cover. You've got medical people on the site. You've got other, supporting staff who might be working in a hub in and out, and they might be able to see their patient who's previously been looked after in the community now as an inpatient or now as a day case patient. So it was just a thought, Sarah.
That's actually been discussed and actually in two parts. So with the project as it stands today, a lot of what's come out of the workshops with the stakeholders has been the wish to provide greater outreach into the community. So that part will definitely form the project in some way, though there will be a community element to it. With regards to the primary care premises, that has been discussed. But the strategic assessment that was carried out for this project that covers the scope only covers the inpatient services. So I think another strategic assessment is going to be drafted that will cover the primary care element of it.
Okay, that's helpful. I just think it's a great opportunity, especially when you've got a good site like that to start to bring things together. And what better way to do that than physically? But thank you for your response. Thank you.
Yeah, I noticed Shona Hyman's hand is up too. Shona, would you like to come in?
Yes, apologies, I was still here, so I hope it's appropriate for me to comment. And I would agree with Pat's comment, and I think, as Sarah's highlighted, primary care has been part of the discussions at different time points. So I think everybody's really supportive of the variation in the relation to models that can happen going forward. And there's been a number of discussions over quite a long period of time, as highlighted with this project, in terms of moving that forward. But I think because of the size and scope, it was agreed to split it so that they were managed slightly separately. I guess there is a risk in that it may be that the sort of more inpatient and directly community work linked to that, it moves forward at a different pace, which obviously would create some risks, because I do think there are advantages of co-locating with a range of services, but that's not just health. And we do have examples where we've co-located with children and family services, education and things. So hopefully that work will be able to progress fairly soon.
Yeah, because you can put libraries and, you know, sports facilities and community facilities. So I absolutely support that, Shona. Yeah, 100%.
Martin?
Sorry, Chair, just a very brief question. Has a site actually been chosen, and if so, where? Or I couldn't see details of that in the papers.
No, not yet. That's the next step. That's one step ahead.
Sorry for asking a question that was too far
That's
ahead.
okay.
Sorry.
We're just smiling because we talk about that quite a lot.
Okay, no further hands. Thanks very much for spending so much. I keep going on about this, don't I? Spending so much of your time here today, Sarah. We're asked in the recommendations to note the content of the report and to continue support the development of the initial agreement, which we most certainly do. Annie, would you like to comment?
I would just like to say that I'm delighted to see such good equality impact assessments done. The NHS could learn quite a bit from our health and social care partners. So thank you. It's good to see that.
Well, just this particular one, I think, Annie, to be fair. I'm not sure that they all do it as well as this. That's my point.
No, there's been a few in today's papers, so I just wanted to say that it's good to see it. Thank you.
Yeah, absolutely.
Well done, whoever wrote it. Who was it?
Thanks. That was my first attempt. Jenny might have corrected it quite a bit, though.
Well, your work's certainly appreciated then. Thanks very much for coming today.
Thank you. Bye.
We're not far from the end now, folks. Sorry. Yeah, item 16, Willie.
Yeah, thanks very much. And just confirming item 15 had been dealt with. So item 16, financial monitoring, is before you. I believe that Christine Jones and Dave Berry will speak to the item. Is it page 185 of your agendas?
Yeah, I'll pick this one up. I'm very conscious of time and I'll try and make this as quick as possible so everyone can go off and get their lunch. It's obviously our standing item, and just for noting, so the finance report is presented for you as with the position at the end of February, and at that point we're looking at projecting for the full financial year an underspend of 2.155 million for 21-22. That's based on the assumption at that point that all of our additional COVID expenditure was fully funded from additional Scottish Government allocations. And we have now received additional funding from the Scottish Government. We've got that clarified, so we know that that's all okay and that risk has been alleviated and removed. So the figures for the different service areas remain relatively comparable to previous reports that we presented to you. I don't think there's anything significantly shifted, and the details of that are in the breakdown in the appendices. One particular point to note, again, is the continuing positive position of the GP prescribing budgets, with an underspend of 1.6 million projected for the year, so that's obviously a significant part of our overall position. We'll obviously continue to work with different services, the ones that are overspending, to look at the areas of the pressures and also the areas of opportunities and the reasons behind the underspending areas to understand that. As you know from previous reports that we've presented, the IJB received a substantial amount of additional funding during 21-22. The breakdown of this is in 4.8.2. A lot of that funding is recurring into 22-23 and beyond. due to a lot of timing issues, COVID issues over the last few months, recruitment challenges, we are expecting a significant amount of that will be unspent at the end of the year. And that's going to inflate our year-end reserves position as that'll drop down to the bottom line or be carried forward in reserves. But obviously a lot of that funding's already been built into our 22-23 budget planning and our developments and our strategic planning for going forward. From a finance team point of view, just to add a couple of extra points to it, we're currently working through our year-end position for the IJB. So far, without wanting to tempt fate, the figures appear to be in line with figures that we've already presented to you. So touch wood, there are no surprises coming through, but so far so good. I'm hoping that I'm not tempted fate by saying that, but I've got my fingers crossed everything else continues to go relatively smoothly. At 4.5.3, there is mention of the additional Scottish Government COVID allocation. I can confirm, I don't think the figure's in the report, but I can confirm that that amount is 16.78 million that we received towards the end of the financial year. We do know that a small portion of that will be required to top up our 21-22 COVID funding that we'd previously received and carried forward. But the majority of that will be carried forward into the 22-23. So again, that's going to significantly inflate our reserves and position for the financial year. Some of that is obviously going to continue to support our ongoing spend, our ongoing transition as we move out of the remobilisation and recovery phases and move towards our new strategic positions. Some of it will also be required through NHS Tayside, so ongoing discussions there, things like for the inpatient mental health position, which is delegated to the IJBs, and also supporting some of the unscheduled care pathways. So some of that conversation is still ongoing with NHS Tayside. One other point just to add that we've identified and confirmed as we're moving through the year end, in 4.3.5, there's mention of a likely contribution to hosted inpatient mental health overspend for 21-22, with this being expected to be about 500,000 at most. We have got that confirmed now that it's 276,000, so less than the report actually alludes to. And just finally, we'll be presenting a year-end position report along with the draft annual accounts at the next meeting in June. And just for the minute as well, we have noted the action tracker point about enhancing the reporting going forward. So we'll pick that up from when we report on the 22-23 position and our first report from August onwards. So hopefully there's nothing else, but if there's any comments or points, I'll happily take those, or unless Dave wants to chip in with anything else.
No, if this is my last meeting, I'd certainly be happy with the financial situation as I depart, and thanks for all the work that you've done and providing us with a balanced budget last month and this most recent update. You know, no nasty surprises as you say. So thanks very much for that. I don't see any hands, so we're asked to note that, and we look forward to your report next month. Thank you. Well, this is a code of conduct, right?
Yeah, thanks very much. Here, yeah, the remaining items, item 17, the code of conduct, page 197 of your agendas. It's straightforward in nature, and you're asked to agree to those recommendations. And Roger Menny's here to speak to the item, I believe.
Thank you, Roger. Would you like this? Yep.
Very brief, given the time, Chair. Just to say that, as is indicated in the note, this code of conduct is asked to be adopted by IJBs by the 10th of June, so the recommendation is that you should do that today, and arrangements are being made for induction briefings after the council elections next month, and invitations will be sent out to all members of the board who may wish to join, when I'll be very glad to discuss the provisions of the Moral Code in detail with all members.
Great stuff. There's nothing controversial here. I don't think. I'm presuming everyone's read it. Annie?
There's nothing controversial, but Roger, I think maybe instead of people attending if they wish to, I think we'd have to be a bit of a moratorium. If we're board members, we need to make sure that if there are briefings that we definitely attend them. So that's all I wanted to say.
A 3-line whip.
Can I say I would be very supportive of that. I think the issue that we've had, Annie, is that I've tried to set up briefings in the latter part of 2021 and in the early part of 2022, and I do know that because people's diaries, it can be difficult for people to attend. What I would say, however, is if members are unable to attend the briefings at the times that they're scheduled, they're very welcome to contact me at any time, and I'd be happy to have a one-to-one session with any member on any items in the code.
That's very kind of you, Roger. Donald?
Thanks, Chair. I mean, this may be a stupid question, but I keep reading and rereading this point about the code applying, but paragraph 3.10 being excluded. And when I look at 3.10, it's about respecting and complying with rulings from the chair. And God forbid that Ken would want us to become unruly or non-compliant. But why was that one so particularly difficult for IJBs?
Ask that, actually, yeah.
My understanding was that it was indicated that it wasn't to do with rulings from the chair, it was matters of collective responsibility, and it wasn't regarded as appropriate for IJBs to actually adopt that particular provision. But that's one of the items we may wish to discuss in more detail when we have the induction briefing.
Oh, right. Should the reference then be to 3.11 rather than 3.10?
I think that's probably right, Donald, but that's the way that the guidance was actually written.
Okay, thanks, Roger.
Yeah. So, right, we note and approve then, yes? With the exception of paragraph 3.1. Oh, 1010, yeah.
Okay, thanks very much, Chair. Then takes you on to item 18, attendances, which are for noting.
Oh, the meeting's nearly over then, eh? Oh, this has been a marathon. Sorry about that, but so many items on the agenda. Like, we wouldn't be doing justice to them if we'd done this in an hour and a half. So that's it then. It's just the date of the next meeting, isn't it? Which is the Wednesday, 22nd of June, 2022 at 10 o'clock. And thanks so much for your attendance today, and your the vast majority of you have stayed right to the end, and those that couldn't only left because they had other meetings. So thanks very much.